Good morning, friends. Am I audible well?
Yeah.
Yeah. Respected President, Dr. Laul sir, dignitaries on the dais, panelists, esteemed speakers, my dear TOGS friends, it's a great honor to begin this next meeting or the next Adolescent Health CME on what better day than Valentine's Day. तो आप सबके लिए शुरुआत में अर्ज करना चाहूंगी कि तुम हमें अपनी जान से ज्यादा प्यारे हो, तुम हमें अपने जान से ज्यादा प्यारे हो, हम सिर्फ आपके हैं और आप सिर्फ हमारे हो. So wishing all my dear Toxians a very, very happy Valentine's Day. And I have this lovely Valentine poem that I have brought in to usher Valentine's Day for all of us. That I'm a little Valentine, red and white. I'm a little Valentine, red and white, with ribbons and lace. I'm a beautiful sight. I can say I love you on Valentine's Day. Just put me in an envelope and give me away. Welcome, one and all. And we have all our esteemed panelists and speakers ready. So without much ado, I will request our President, Dr. Laul, to please give the presidential address.
Hello, warm welcome to all the delegates participating in this live webinar organized by Thane Obstetrics and Gynecological Society Team 2021. The topic today is Adolescent Health, and after the beautiful introduction and poem recital by our ace moderator, Dr. Supriya Arwari, we will be starting this webinar. The organizing secretary is Dr. Datta Panandikar. And the first talk will be, we are honored to have Dr. Shashank Joshi, who is a Padma Shri, and he will be talking on thyroid disorders in women and adolescents. And that will be followed by another talk by past President MOGS, Dr. Nozer Sheriar, who will be talking on managing unwanted pregnancies, preventing and managing unwanted pregnancy in adolescents. And then that will be followed by power pack panel discussion on various aspects in adolescent health, that is the polycystic ovaries, hyperandrogenism, menstrual disorders, hirsutism, all requiring special form of treatment which is different from adults. So we are very much thankful to Bayer for giving us this academic platform, and I know you all are waiting for our honorable speaker, Dr. Shashank Joshi, to start. So I will hand over the mic to Dr. Supriya Arwari, thanking all the delegates and asking her to start the scientific deliberations. Over to Dr. Supriya. Supriya, unmute kar. Please unmute yourself. Haan. Dr. Supriya. Okay. Haan. Unmute kara. Please unmute kara.
Sorry, there was some issue with my net.
Okay.
I would now like to invite the chairpersons for today. We have a galaxy of chairpersons who will be chairing the sessions for us. First and foremost, I would like to invite Dr. Jainarayan Senapati, who is none other than the Vice President of TOGS. Zoeb, can we have the CV? Shashank, just give us a minute. Zoeb, can you please share the slides for the chairperson CV, please? Thank you. Yeah, this is our program. First and foremost is our chairperson, Dr. Jainarayan Senapati, who is the head of department of Shivaji Hospital, Kalwa. Please give me the next slide, Zoeb. Yeah, Dr. Senapati, yes. Very proud to say that he belongs to Bhiwandi, our mentor, friend, philosopher, guide, UG and PG examiner at Mumbai University, and examiner for DGO, FCPS, and CPS. Committee member of the maternal death review at TMC. Various publications to his credit. I don't think anybody in this crowd needs an introduction to him. The next chairperson, can I have the next slide, is Dr. Ajay Kumar Bhaskaran, again a renowned gynecologist from Bhiwandi. He has worked as a research assistant at the Kerala Registry of Epilepsy and Pregnancy, has papers published on seizures in pediatric and ANC groups, and he's practicing in Bhiwandi since the last several years. He's the messiah of all the Bhiwandi lady gynecologists. Welcome, Dr. Ajay. The next slide, please. We have Dr. Rachna Deshpande, who is again an MS OBGY consultant obstetrician gynecologist at MediSearch Center, attached to Kaushalya, FICOG in reproductive medicine from Sushruth Hospital, and trained in ultrasonography, hysteroscopy, and laparoscopy. I would now request Dr. Senapati sir to introduce the first speaker for the day, Dr. Shashank Joshi, Padma Shri, an eminent endocrinologist, a very dear friend. Before I hand over to Dr. Senapati, may I put these few words for Dr. Shashank कि भगवान ने अनमोल रतन गिन चुन के बनाए हैं. भगवान ने अनमोल रतन गिन चुन के बनाए हैं. उसमें से कुछ खास रतन हमारे बीच में आए हैं. ऐसे ही एक रतन है हमारे बीच, डॉक्टर शशांक. And I'll request Dr. Senapati to please give a formal introduction.
Yeah, good morning to all the delegates, speakers, and panelists. And warm welcome to Padma Shri Professor Dr. Shashank Joshi. And I'm happy to introduce, he's from my alma mater, Grand Medical College and JJ Group of Hospital. He's a gold medalist and has topped all years of MBBS, MD, and DM. Dr. Joshi is the Dean of Indian College of Physicians and the President of the Association of Physicians of India, the Research Society for Study of Diabetes in India, and the All India Association of Advancing Research in Obesity. Dr. Joshi is involved with the activities of the American Association of Clinical Endocrinology and is serving as the chairperson of its India chapter. Dr. Shashank Joshi was honored by the Government of India by awarding him the Padma Shri in 2014 in recognition of his effort to the cause of the medicine. He is also a recipient of the International Clinician Award received at 21st American Association of Clinical Endocrinologists Annual Scientific and Clinical Congress in Philadelphia. He has delivered around 200 orations and nationally and internationally. He is a famous physician and endocrinologist that everybody knows. I don't think there is any need to give any introduction for him. He is so famous in his area. Thank you very much.
Thank you, sir. And Zoeb, can you stop slide share? And we'll request Dr. Shashank to please start his slide share. And friends, may I please tell you, he is out of station and he has really kindly allowed us to become a member of his fan club and come here on Valentine's Day. So happy Valentine's Day, Shashank, and we are all ears.
So thank you, Dr. Supriya, for your extraordinary moderation skills. I'm not as eloquent as you are. And thank you, chairpersons. At onset, I would like to thank Dr. Loel and the whole group of Thane Obstetrics and Gynec Society for having this CME on Valentine's Day, and including thyroid which is a lost cause, disorder. And I'm going to talk on thyroid disorders in women and adolescents. Are my slides visible and am I audible?
Yes.
Okay. So, what I'm going to allude to is that I'm going to discuss thyroid disorders in women and adolescents. And that thyroid in women is very prevalent, particularly in the female community. There is a gender bias. And we know that thyroid disorders occur from menarche to menopause. And today our focus is going to be mainly adolescent because it's an adolescent CME. So the first thing which thyroid can do is it can delay puberty and occasionally can also cause precocious puberty. It clearly can cause menstrual abnormalities. It clearly is linked to menstrual abnormalities. It's clearly linked to infertility. It has issues during pregnancy and of course issues during menopause as well. So let us look at the first thing, which is very common with thyroid and puberty. All of us know the existence of a pubertal goiter. And pubertal goiter in the pre-iodinization phase was a very common entity. It is a smooth diffuse goiter which comes and goes after puberty. And usually, essentially, there is no pretty obvious treatment for a puberty goiter. But obviously, we know that in reproductive function, thyroid hormones are very crucial and critical. And we know that when we go through puberty, some endocrine changes occur. So the first simple endocrine change which occurs is that we know that the pituitary gland, which is the anterior pituitary gland, has something called as somatotropes. Somatos is growth, and the somatotropes in the anterior pituitary secrete growth hormone. And you know that the somatotropes, lactotropes, and thyrotropes. Somatotropes make growth hormone, lactotropes make prolactin, and the thyrotropes make TSH. They all are staying next to each other, they are neighbors. And when the growth hormone secretion in the anterior pituitary goes up during puberty, it actually co-stimulates the thyrotropes and increases the TSH secretion from the anterior pituitary. And that really increases our body's metabolic rate and promotes tissue growth. In normal physiology, there is a very unique unison between our somatotropes and thyrotropes, and the GH and TSH work in harmony to improve metabolic rate and promote tissue growth. And that really causes a little bit of increase in the thyroid volume, which is a normal physiological adaptation to body and sexual development, which causes that little bit of puberty goiter, which I was alluding to. Now, during puberty, and particularly in children and adolescents, the commonest thyroid disorder or abnormality is hypothyroidism. And diagnosis of hypothyroidism is very crucial in adolescence because it retards the growth of height and development of secondary sexual characteristics. And we know how obsessed people are with height, and everybody wants to be as tall as possible. And obviously, when you get hypothyroidism, it is the most reversible cause of proportionate short stature. I would request everybody to mute because otherwise it will distract everybody. And if Zoeb, you can ask or mute others except me, it would be ideal so that the background filter will be easy. So hypothyroidism during adolescence retards growth, and the most common reversible cause of proportionate short stature. Now remember, short stature can be proportionate and disproportionate, is hypothyroidism. And it also delays the development of secondary sexual characteristics. Delayed onset of puberty is a very common characteristic of hypothyroidism. And very rarely in hypothyroidism in adolescents, you can get an incomplete isosexual precocity, which means you might get a precocious development of breast or internal genitalia in girls. So if you have a girl at a young age below 9 with an abnormal breast tissue or internal genitalia, which is incomplete isosexual precocity, always rule out hypothyroidism because it's a reversible cause. So as I said, precocious puberty is a very unusual but not uncommon presentation of hypothyroidism. And in the last couple of years, almost every week or every 2 weeks, I see one case of precocious puberty in my busy practice. Usually, the classical features of precocious puberty, which is incomplete and isosexual, is the onset of thelarchy, which is breast development, often accompanied by galactorrhea, followed by menarche in absence of hair development. So typically, the incomplete isosexual precocious puberty is diagnosed by development of a breast bud with or without breast milk, with menarche, and all this almost come one after another in a span of less than 4 to 8 weeks, which is 1 or 2 months, but there is absence of hair development. Another clinical cue of hypothyroidism in such cases is that the linear growth is delayed. So if you do an X-ray hand with the wrist joint for the bone age, you can see that there is a delay, and this is very opposite to what is seen in patients with true precocity. So obviously there is a little differential here, but that is left for the endocrine world to look at. But clearly it's a very, very simple thing to do. So obviously we know that there are many causes of precocious puberty. And I'm certain that as gynecologists, often you are encountered with this precocious puberty. We know that there is a true precocious puberty, which is gonadotropin dependent. And this gonadotropin dependent precocious puberty usually is idiopathic, or there are organic brain lesions. But one of the common causes of gonadotropin dependent true precocious puberty rarely could be prolonged untreated hypothyroidism. Often I have seen girls from rural India which come to me who have been missed, and the hypothyroidism has persisted over a year or more and has not been treated with TSH often above 40 and T3, T4 which are very low. which are untreated prolonged hypothyroidism, and they have true precocious puberty, which is gonadotropin dependent. So always remember that whenever you see a precocious puberty which is true, always look for untreated prolonged hypothyroidism. Also remember that you can get a combination of gonadotropin dependent and gonadotropin independent puberty, which often is seen when we give a little bit of steroid to a 17-hydroxylase deficiency or congenital adrenal hyperplasia, which is not uncommon in hairy women, particularly from north of India. Occasionally, we do see congenital adrenal hyperplasia. McCune-Albright syndrome, which is of late onset, and also in males, you know that there's an entity called familial male precocious puberty, which can be late, which is a combo thing. The other common thing which we see in precocious puberty is partial incomplete precocious puberty, and that is more commonly seen in hypothyroidism, particularly premature thelarchy followed by premature menarche. But you know that precocious puberty can occur in isolation, which is called as incomplete, which could be an adrenarche, it could be a thelarchy or breast bud development or menarche. And remember the TM, which is thelarchy followed by menarche with absence of hair, is also a signal of hypothyroidism, which we should always never forget. Enough about precocity. Let's move to thyroid and menstrual irregularities, which are also pretty common. And we know that in hypothyroidism, we get normally a lot of menstrual irregularities. Normally, the gonadotropin levels in hypothyroidism are usually normal. But once there is untreated hypothyroidism, the LH response to GnRH is blunted or delayed and 3 times greater than the normal population. So occasionally in hypothyroidism, you can get oligomenorrhea, very rarely amenorrhea. Also, commonly you can get polymenorrhea and menorrhagia. So remember that these two are probably much more commoner than oligomenorrhea and amenorrhea, but you can get a full spectrum of menstrual irregularities in hypothyroidism. Usually an estrogen breakthrough bleeding is secondary to an ovulation. And we also know that in hypothyroidism, you get hematological defects of hemostasis. I'm certain that many of you all know that when there is untreated hypothyroidism, you get decreased level of factor 7, factor 8, factor 9, and factor 11. And this is something very well known. So a lot of homeostasis defects are seen with untreated hypothyroidism and is not related to thyroid antibodies. So remember that usually the GnRH response is deferred or delayed. Usually you can get polymenorrhea or menorrhagia in hypothyroidism. Occasionally you can get oligomenorrhea and amenorrhea. Rarely you can get a estrogen breakthrough bleeding secondary to an ovulation. Remember that with hypothyroidism, you can get homeostasis or hemostasis defects of factors 7, 8, 9, and 11. And there is no linkage with thyroid antibodies or autoimmunity. So what are the causes of amenorrhea? And in causes of amenorrhea, chronic diseases and thyroid diseases are important treatable causes. We know both hypo and hyperthyroidism are important causes of amenorrhea, which we often see during the adolescent age. And also rarely remember, adrenal causes also should never be forgotten. We know that amenorrhea can have congenital causes, which we all know, which I don't want to go into delay, constitutional delay, genetic causes, excess prolactin, pituitary gland and stalk damage, simple eating disorders or athletes can have amenorrhea, mood disorders, stress, psychiatric illnesses can have amenorrhea. But remember, a very reversible cause of amenorrhea is thyroid disorders and adrenal disorders, including, both Cushing's and Addison's, which can cause it. Of course, ovarian causes, eugonadal uterine issues, eugonadal vaginal and hymenal issues are something which we all know are structural issues, which all of you all deal very regularly, but never forget chronic disease and thyroid. Also remember that Endocrine Society has come out with recommendations for functional hypothalamic amenorrhea. So when we are evaluating a patient for functional hypothalamic amenorrhea, particularly seen in adolescents and women with suspected functional hypothalamic amenorrhea, we recommend that we do the following screening tests like beta HCG, CBC, electrolytes, glucose bicarb, blood urea and creatinine, liver panel, and CRP. And after that, we look at some endocrine issues like a TSH and free T4 because it's a very reversible cause of functional hypothalamic amenorrhea, prolactin, LHFSH, E2, And of course, now AMH is a part of all your recommendations, which we do. Clearly, we know that there is a direct neural interaction between metabolic and reproductive functions. And you can see here that the gonadotropes, pituitary, FSH, and LH, and the GnRH secretions. And we all know that in the hypothalamus, we have the KNDY or the kiseptin, which actually modulates a lot of the GnRH or gonadotropin response. So clearly we have a neuroendocrine connect and a neuropituitary connect or a hypothalamo-pituitary connect, which is linked to the metabolic and reproductive cues, which ultimately impact both metabolic and reproductive action. As I told you, both hyper and hypothyroidism can cause menstrual abnormalities. And you can see in thyrotoxicosis when there is a weight loss, prominent eyes, a little bit of anxiety, lack of sleep, you can early studies show that oligomenorrhea and menstrual irregularities are almost there in 2/3 of patients. But the newer studies feel that abnormal menses are seen in much lower percentage. In the good old days, it was difficult to pick up thyrotoxicosis, and the longer is the delay in the pickup, more is the menstrual abnormalities. Earlier you pick it up, less is the menstrual abnormalities. So this is global data, and the global data, thyroid is picked up much earlier, but in India, we still see a lot of delayed diagnosis, and therefore we still see oligomenorrhea and menstrual irregularities with thyrotoxicosis. Similarly, in the good old days, when hypothyroidism came to us untreated, which we still see occasionally, you could get menstrual abnormalities in almost 80% of cases. And in recent studies, it has come down to 20%, obviously because of a better way of diagnosing these disorders. As I told you, what are the hormonal changes which occur in both excess thyroid and hypothyroidism? So we all know that when there is thyrotoxicosis, whether it's male or females, the SHBG goes up, while when there is hypothyroidism, SHBG goes down. We all know that the E2 goes up or is normal in thyrotoxicosis, and hypothyroidism in females, particularly, there is a lowering of the E2 as well as the estrone. And the production rate of estrogen is unchanged in thyrotoxicosis, but is clearly blunted or decreased in hypothyroidism. Also, we know that the metabolic clearance rate of estrogens or androgens is universally decreased, whether it is hyper or hypothyroidism. And the free E2 is increased in males only, but not in females, and is normal in cases of hypothyroidism, which is untreated. We also know that the androstenedione or the delta 4 is increased in females with thyrotoxicosis and is decreased in hypothyroidism females. And clearly you can see that the various other are more or less normal. What is unique to see is the GnRH response of LH and FSH in hyperthyroidism. The output is more, while there is a blunting of LH FSH response to GnRH when there is hypothyroidism. Let me move on to the other problem, which is often seen in adolescence, a unique combination. You know that the third commonest endocrine condition on planet Earth after diabetes and thyroid is PCOS. And we know that thyroid and PCOS are uniquely connected. So clearly we know that two of the most common endocrine disorders which occur in general population is the polycystic ovarian syndrome and thyroid disorders. We also know that hypothyroidism and PCOS are completely different on etiopathogenesis. However, both the entities have some features which are quite common. We know that in the ovaries in thyroid disorders, what happens is that there is an increase in ovarian volume and cystic changes in ovaries, which have been reported with untreated primary hypothyroidism. When there is primary hypothyroidism, in the hypothalamus, the TRH, thyroid releasing hormone, goes up, which actually co-stimulates. Co-stimulate is the word. Both the lactotropes and thyrotropes, which reside in the pituitary, the anterior pituitary, and this co-stimulation of the lactotrope and thyrotrope, which are residents and neighbors of each other in the anterior pituitary gland, increase both TSH and prolactin. What happens because of increase of TSH? As gynecologists, you know, there is a spillover effect on the FSH receptors, and there is possibly a link to collagen deposit in the ovaries. When there is a co-stimulation of the lactotrope, when the prolactin goes up, we know two things happen. One is at the adrenal level, prolactin stimulates the adrenal DHEA, and causes a follicular maturation arrest, which I am certain that all of you all in your fertility world know it very well. And also we know that when the prolactin goes up, there's a decreased frequency of the GnRH, increase FSH relative to LH, and you get the cystogenesis or the follicular cyst formation. So clearly, when you have a lot of uncontrolled, undiagnosed hypothyroidism, TRH will co-stimulate prolactin and TSH, and it's the prolactin which actually is more, deleterious to the ovaries, because the follicular cysts are predominantly formed because of the increased FSH relative to LH with an abnormal ratio and a decreased frequency of GnRH, and obviously the adrenal DHA goes up following the follicular maturation arrest as a sequelae. The persistently high TSH has a spillover effect on the FSH receptors of the gonadotropes, which probably is linked to collagen deposition in the ovarian milieu. So clearly, when we look at the thyroid disorders in females with PCOS, multiple studies both from China and India have shown that there is a higher prevalence of goiter and subclinical hypothyroidism in PCOS patients compared to control, and that being around 22% and 8% being the percentages. And obviously a higher frequency of subjects with subclinical hypothyroidism, autoimmune thyroiditis, and goiter are seen. So what is the feature when there is a PCOS with thyroid? A goiter and hypothyroidism, which is subclinical, which means T3, T4 is normal and TSH is elevated. Autoimmunity is pretty common in PCOS, and one of the proposed explanation for occurrence of increased autoimmune disease in female compared to males is linked to hyperestrogenism. We all know that estrogen receptors have a proliferative action on the B lymphocytes, and estrogen receptors are also present on the T cell as well as macrophages. So remember, there's a higher incidence of autoimmunity among females compared to males is linked to the estrogens. And we know that higher autoimmunity, which is seen in females, is explained by the estrogen receptors of the proliferative nature on the B lymphocytes, as well as the T cells and macrophages. Clearly, you can see here, this was something from India. My good friend Mohammad Ashraf Ghani from Srinagar had published this data some time back, that in PCOS girls, adolescent girls with euthyroid chronic lymphocytic thyroiditis. So a significant higher prevalence of adolescent girls have euthyroid chronic lymphocytic thyroiditis. They have a higher BMI, higher waist circumference, higher systolic BP, which is very typical of the metabolic milieu. Similarly, if you look at various global studies, the impact of autoimmune thyroiditis on reproductive and metabolic parameters with PCOS is very well illustrated. It is very clearly seen that patients who have a dual defect of autoimmune thyroid disease with PCOS have probably a lower prevalence of elevated testosterone, free androgen index, and androgenemia. So remember, when there is a coexistence of PCOS with autoimmune thyroid disease, probably the testosterone levels with the PCOS woman may be lower, so they are less androgenic. So AIT is more prevalent in PCOS than controls, and PCOS patients with AIT have less severe hyperandrogenemia and hyperandrogenism and are less likely to suffer from an elevated metabolic risk. What is the link? The link between the two conditions, PCOS and thyroid, is probably the increased BMI and insulin resistance. We know that as the body fat increases and the BMI increases, which is an integral part of PCOS, a large majority of the cases, the TSH is always higher in people with a higher BMI. So as illustrated in this graph, you can see obesity increases adipose tissue and increases the pro-inflammatory markers, which increases the insulin resistance and decreases in the pituitary the dopamine D2 activity, which in turn will stimulate the thyrotropes to increase the TSH. And that probably is the link which drives a little bit of subclinical hypothyroidism and autoimmune thyroiditis in PCOS women. Let me look at the last couple of points, which is a link between thyroid and infertility. We clearly know that the ovulatory disturbances are classically seen in hypothyroidism. We clearly know that when you have hypothyroidism, TSH has an analogy with FSH, and there is a pseudo feedback because of TSH as a spillover phenomenon on inhibition of LH and FSH. We also know that in hypothyroidism, the SHBG pool is decreased, androgen clearance is decreased, hypothalamo-pituitary changes in hypothyroidism impair the LH response to GnRH stimuli, and the higher the TRH, more is the prolactin, and increase ovarian volume and strobal deposits. So obviously that all leads to a higher milieu of ovulatory disturbances, which in turn result in infertility. So clearly, if you look at an IVF setting with hypothyroidism, clearly you can see the expression of thyroid disruptors as well as various deiodinase and transporters of thyroid, whether it is the oocyte, whether it is endometrium, whether it is T3, whether it is T4, on the placenta, on the embryo, on the sperm, there is a clear link at each phase of thyroid dysfunction, which is directly linked in pathogenesis or infertility. So clearly there is very good data for the last 20 years to show prolactin and TSH has a link in an IVF population, and the link between fertilization and thyroid function is something which all of you all see as gynecologists. Clearly now there's enough data to show that TSH levels are significantly higher in women who produce oocytes that fail to be fertilized, and this finding persisted after adjustment of several covariates, including sperm motility. So clearly that we know higher TSH means that the women who produce oocytes are unlikely to fertilize, and that's something which is very well known. So TSH predicts poor fertilization of IVF and reflects the importance of thyroid hormone in oocyte physiology. As a fertility specialist, I'm certain that you know this fact. A couple of years back with Dr. Palchetkar, when I was the secretary of the Indian Thyroid Society, the ITS and FOXY came out with recommendations for management of thyroid dysfunction in pregnancy. And we know that a routine TSH screening is recommended for all TSH seeking infertility and antenatal care. We clearly also know when we pull all the studies of autoimmune thyroid disorders and female infertility, the relative risk of increase of infertility just because of autoimmune thyroid disease is 2.1. Also, we clearly know when you summarize all the data of autoimmunity, thyroid dysfunction, and fertility, clearly the antibody positivity has an odds ratio of 1.47, and that happens more frequently. So even if there is euthyroid autoimmune thyroid disease that affects 5 to 10% of women of childbearing age, and we clearly know autoimmune thyroid disease is more prevalent in infertile women and has been associated with increased miscarriage rate, decreased oocyte fertilization and pregnancy rates among women which are undergoing ART. Presence of thyroid antibodies in the follicular fluid is seen in women who have autoimmune thyroid dysfunction. And we also know there's a direct link of autoimmune thyroid diseases with endometriosis, PCOS, and premature ovarian failure. We also clearly know that simple thyroxine can be considered to treat euthyroid, thyroid antibody positive women who are undergoing an ART, given the potential benefits compared to the minimal risk ratio. When it comes to subclinical hypothyroidism and infertility, the thyroxine might improve, and there's a good analysis to show that when we give thyroxine, the likelihood of a positive delivery rate is better, as evidenced by various studies of Negro, Rahman, and Kim et al. So several meta-analyses now show that if you give a small dose of thyroxine supplementation, it improves clinical pregnancy outcomes in women with subclinical hypothyroidism and or autoimmune thyroid dysfunction undergoing ART. And even prospective randomized trials have shown that this can be very, very clearly showing that there's a higher number of grade 1 and grade 2 embryos, embryo implantation rate and live birth rate, and significantly lower miscarriage rates. So clearly thyroxine supplementation might have a role, and there's adequate data in various multi-analysis to justify the need for the same. So given the potential to reduce miscarriage rate, thyroxine supplementation has been recommended for infertile women with subclinical hypothyroidism or thyroid autonomy undergoing IVF and ICH. So obviously thyroxine makes a difference, and I think I'll stop here. What I've tried to do is cover an overview of adolescence, thyroid disorders, women, and thyroid disorders. I'm certain that I have a little bit overshot my time, and if you have a couple of quick questions, I'll be happy to take those questions. Thank you for a patient hearing, and once again, I thank Thane Obstetrics and Gynec Society, Dr. Avari, Dr. Laul, and all the office bearers of Thane Obstetrics and Gynec Society for allowing me to speak on thyroid, which often we don't hear much about. Thank you so much.
Thank you very much, Dr. Shashank. And if the delegates have any questions Please, can you put it in the chat box? Meanwhile, Shashank, I have a query. When we are looking at the adolescent population, are there any different set of levels that we look for, like redefining the levels in which we should interpret thyroid disorders in, or are they the same as what are applicable to the adult population? And when we give the treatment, should we be giving like according to the weight or according to the age? If you can just clarify a few things here.
So two things: if the weight is below 20 kilograms, give it per kilogram body weight dose.
Okay.
Second
Yeah.
thing is that there are no different normative values as in pregnancy for adolescent population.
Okay.
So
Okay.
only in pregnant situations we have a different reference ranges for each trimester, but there are no different reference ranges for the adolescent population for thyroid.
Okay. Any other questions? Would the chairpersons like to make a comment? Senapati sir? I think he's... Laul sir, would you like to make a comment?
Yeah, sir. Thank you very much. The talk was very informative and very that means cleared my ideas that small dose of levothyroxine will help in subclinical thyroid and also autoimmune thyroid disorders, and that will help in continuing pregnancy and a successful pregnancy. I think that is a very clear-cut take-home message from this talk. And after, I think with this wonderful talk, we will thank Dr. Shashank Joshi. And if there are any questions, we will take those questions. And if there are no questions, I think Dr. Supriya, you can proceed further.
Okay. I think Dr. Senapati has joined us, sir. Would you like to make a comment?
Yes, okay. Dr. Joshi has elaborated clearly the association of thyroid disorders with adolescent people or adolescent women, and including the infertility, PCOS, and everything he has covered so nicely. There are a lot of take-home messages already. Dr. Lal has told that, and with a lot of thanks to Dr. Joshi that he has spared his time and give us a good talk about thyroid and clear out certain doubts about thyroid disorders along with adolescent females. Thank you, Dr. Joshi.
Thank you very much, Dr. Shashank, for gracing the occasion for us, and all the best for your FB Live programs. Thank you so much. I think now we should proceed with the next talk. Dr. Nozer is here, and it's such an honor to have such great speakers here, and they are so busy in their individual lives. And Dr. Nozer has just probably delivered a patient, and he joined in. So really indebted to you, sir. Thank you so much. And I'll request our chairperson, Dr. Rachna Deshpande, to please give a formal introduction to Dr. Nozer, sir. On my personal behalf, I would like to invite him. It's a real honor because he was my teacher in post-graduation, and really, sir, you have shaped the way my thinking has changed, how I have approached to my patients. And therefore, before I hand over to the chairpersons, I have these few lines for you. कि गुमनामी के अंधेरे से पहचान बना दिया, गुमनामी के अंधेरे से पहचान बना दिया, दुनिया के गमों से अनजान बना दिया, ऐसी कृपा हुई परमेश्वर से कि मिले ऐसे गुरु जिन्होंने सिर्फ अच्छा डॉक्टर ही नहीं, अच्छा इंसान भी बना दिया. Thank you so much, sir. Much indebted. And may I request Zoeb to please share sir's CV slide, and I'll request Dr. Rachna to please give a formal introduction.
Good morning, everybody. Dr. Nozer per se needs no introduction. Dr. Nozer is a past Secretary General and past MTP Chairperson of FOXI. He's past President MOGS. I think the wrong slide is being...
Yeah, it's here.
He's the past President MOGS. He's attached to Breach Candy Hospital, Hinduja Hospital, and Holy Family Hospital. He's the scientific chairperson of the 22nd FIGO Conference, Rio de Janeiro. He's delivered 16 orations, over 500 presentations, edited 16 books, and published 35 papers and 70 chapters. He's received FRCOG Honoris Causa. He's received the AOFOG Young Gynecologist Award, the FOXI Dr. Hansotia Best Committee, and Dr. Datta Best Publication Award. Dr. Bhatia, Young Scientist, Dr. Ganadhara, Community Service, Dr. Desai, Excellence, Mr. and Mrs. Pandit Women's Empowerment Award. He's a member of Technical Advisory Group, WHO, SEA Region, South Asia, member governing body, Guttamacher Institute, and C3 co-chairperson, Medical Advisory Panel of Family Planning Association of India. We welcome you, sir, and we are eagerly waiting for the talk.
Thank you so
Yes,
much,
Zoeb.
Rachna. Yeah,
Please
could I
allow
share my
sir to
screen?
share slides. Yeah.
So Supriya, the patient, hasn't delivered yet. She's fully
Oh,
dilated.
oh my God.
So I'm going to rush through my talk.
Yes, sir, please.
And I might have to skip the panel discussion.
Oh, that would be a pity, sir.
I know, but so, okay. Do you have my screen?
Yes, sir, very much.
Okay, so Supriya, Dr. Lal, thank you so much. Pleasure to be part of this program and to follow such a fantastic talk by Dr. Shashank Joshi. Well, today is Valentine's Day. It's always a special day for everyone, but more so for young people. So thank you for having the focus on adolescence. Most of what I discuss today is general, but we will focus it on adolescence because we realize that science remains the same. Science doesn't change. It is the practice and the legalities and the regulations that change. And maybe that's what we'll also touch upon today. I think I've got about 40 minutes? Half an hour, Supriya?
Sir, 30 minutes.
Half an hour, sir. Yeah.
Oh, fine, sir. So this is a picture I saw many, many years ago. This was a woman who had come to hospital with a criminal abortion in Chile, a country which didn't allow abortions or contraception. And it was a very moving picture. You can see the compassion in the doctor. And this was her 26th criminal abortion. Now, why does a woman undergo 26 criminal abortions? Because when a woman does not want a pregnancy, she will do anything to make sure the pregnancy goes away. Now, we think this is something that's in Chile. We've had a law since 1971. But yet, in 2018, a colleague of mine at Holy Family Hospital had this patient in Mumbai coming with this kind of a foreign body in her uterus. Not acceptable. And we need to ask ourselves, why does a woman risk unsafe abortion? Well, women risk unsafe abortion for many reasons. One is when the laws are restrictive, and we're going to discuss a conflation between some laws in our country when facilities are few, when there's lack of access to qualified providers, something I am so passionate about, you all know, and I believe women deserve to have a qualified provider accessible. When they perceive it to be illegal, more so when they are marginalized young people, they always think abortion is illegal. When the public sector tends to be insensitive and judgmental, young people are judged, they are afraid to come forward. When there's substantial financial burden, when you're marginalized, you're always exploited. And finally, and most importantly, when there's stigma, there's opposition and there's lack of autonomy. Now, this was an article in the Times of India. I'd been interviewed for that in 2019. And there was, the government puts out its data every year. And in 2018-19, they reported 36,000 MTPs, and of which they said only 11 were below 15 and 500 were 15 to 19. All sounds very good. But when you compared it to 14-15, when there were 30,700 MTPs, 185 were below 15 and 1,400 were 15 to 19. So what happened? Are young people doing fewer abortions? Absolutely not. I believe that this translates into a 95% fall in the below 15 and a 65% fall in the 15 to 19 because we have the Pcos Act. Now, the Pcos Act, has criminalized all sex below 18. We know that in our country, 40 to 45% of women are married off before they turn 18. And yet we've reduced the age of consent increased from 16 to 18. And we know that a private doctor has to inform the police while performing an abortion. Public sector would do so. So what I believe is those young girls, unfortunately today, are seeking out methods of unsafe provision and not coming to safe providers. So I talk about unwanted pregnancy in the adolescent girl, and let's see what the evidence and the practices for prevention and management. Now, Britney Spears, the singer, once wrote, I am not a girl, not yet a woman. All I need is time, a moment that is mine to find a place between. That's what adolescents are asking us for. What are they asking us for? They're 10 to 19 as defined by the WHO. They have earlier biological maturity today, and yet psychosocial maturity is still later. Economic independence is a long way off, particularly in our country, and they will be at higher risk of unwanted pregnancy because they are not good at using reliable contraception. And of course, the unprotected sex also exposes them to an STI risk. So when we look at data, and I found this data from the US, of course, where they showed that of the 25 million teenagers, 4 million were sexually active, 1 million had pregnancies. And their statistics were that half of all young men and women had sex before 17 years in women and 16 years in men. Now, in India, it is estimated that we are 22% population of adolescents, 22%, 1/5, the largest population of adolescents in the world. In India, half of them are married before the legal age of 18. That's the reality. And the Supreme Court has said the Pcos Act still applies to them. So you can imagine that all those 45% who are getting married before 18 and having babies technically come under the Pcos Act. 1/4 between of all women over 20 to 49 are married before 15. And you can imagine the number of pregnancies that would occur. Now, how can we achieve the SDGs that the WHO wants us to achieve by 2030? How do we stabilize our population unless we invest in care of these young people? Now, I just want to use this opportunity to talk to you all about a study on unintended pregnancy in India, because this is not something most people will have read. There was a Lancet article in 2018, a beautiful survey. For the first time, we've got prevalence in India. 4,000 public and private facilities were reached out to. It was 6 states covering 45% of our population. And they found that half of the 48 million pregnancies in India are unintended. 2/3 end in an abortion. And there are an estimated 15.6 million abortions each year. Now, in a parliament question in 2018, we have about 8 lakh or 8.9 lakh MBBS doctors available for active service, including all specialties. So you can understand how a small number of doctors have to try and give this large service, which is why I believe that at some point in time, we gynecologists will have to be big-hearted and allow mid-level provision. Now, what has changed is only 22% are in health facilities, 73% are outside facilities. Medication abortion are the majority, 80%. That has been the magical change. And unfortunately, public health facilities are only now responsible for 5% of overall provision. And a lot of abortion is self-managed. We are worried about that. And there has to be task shifting for what I call as last mile connectivity. Let it be a nurse, let it be an Ayush practitioner. But if he's close to the woman, train that person, register that person, and make. What bothers me is the fact that 5%, that's 500,000, are still unsafe, which is why abortion remains the 3rd leading cause of death in our country. So let's look at the legislative situation. As they say, it's not because things are difficult that we do not dare to do. It's because we do not dare that they are difficult. Well, the POXO Act. I'll start with the POXO Act because we are talking about adolescence. This is an act to protect children from offenses of sexual assault, harassment, and pornography. Very important act. Okay. The section 2 clause 1 is defined child as anyone below the age of 18, which has created part of a problem because young people have sex. They were having sex when I was a resident. They're having sex when I'm a consultant. And unfortunately, while it is sometimes usually consensual, the law doesn't recognize it. Now, what is your responsibility? Your responsibility comes from section 19, clause 1. What is there in blue is what is written. What is there in white is what I've added. Any person who has the apprehension that an offense under the Act is likely to be committed. That means you know that there's going to be sex. Now, for us, it could be counseling, it could be contraception, it could be an STI program. Just imagine you're doing an STI program in young people, recommending condoms. Technically, you may come under the Act. Fortunately, it'll be very difficult for them to prove when you counsel. But then we have another problem. Knowledge that an offense has been committed. Abortion services and obstetric care come under this. Because if there is a pregnancy, you have definitive knowledge. And this information shall be provided to the Special Juvenile Police Unit or the local police. Please understand, there is no exception. You cannot, out of the goodness of your heart, contravene this. At the same time, we as a profession and as organizations have to do something about this. Now, the Mtp Act is an act to protect us. The protection of the Mtp Act is that when you're performing certain MTPs in certain ways, you are protected from the Indian Penal Code. And here, consent is mandatory. And for young people, consent is necessary from a guardian if they are mentally ill or if they are minors under the age of 18. We have all performed MTPs for young girls with consent. In fact, the last time we amended the law, we watered down the consent a little bit and removed the Guardians and Wards Act. So it just has to be a guardian, and anyone over 18 absolutely requires no consent. We also know that there's some very clear indications, but they are so broad-based that anything can come under it. People often tell me, you know, our law doesn't allow MTP in young people. Well, that's not true. If she is a young unmarried person, there's a risk to her life or risk of grave physical or mental health injury. She will come under that. She will not come under contraception. When the law is amended, contraception will become an indication. As of now, it's only an indication for married people. Now, we requested certain amendments. They are hanging in Parliament. Some of them have been passed, some of them forward, some haven't. The first amendment we said was up to 12 weeks MTP on demand. This is such an important basic ask for a country in the 21st century to have. The second is that you allow some pregnancies to be terminated after 20 weeks. Now, here there is a lot of confusion because the committee that I was a part of, I was fortunately to be part of the first committee of the last amendments, the committee of this amendments. We made certain recommendations. Now, people say termination of an abnormal pregnancy till 24 weeks. Not true. The recommendation was, and this will come in the rules, this won't come in the Act, that up to 20 weeks status quo, from 20 to 24 weeks, victims of rape, pregnancies, and the not married, these women need a special dispensation of 1 month more because they always come late. We would like to give it even later, but the problem with later is, and that's the discussion of the committee, you land up with a live neonate, and then what do you do? So till we can change our procedures, and for abnormality, the recommendation is any time in pregnancy, and whatever it is, you know, they are recommending committees, which is terrible. Having a committee judging, worst way forward. What we had recommended was make a gazetted list of abnormalities and let us comply with them. We also brought in confidentiality, of course, hoping that this would help us with the POXO Act, but informing an authority does not breach confidentiality. Now, there's one last thing I want to mention here, and this is apart from adolescence, because you are the champions of women. You have to understand that the IPC has made it a crime for anyone, even a woman performing an abortion on herself. Now, traditionally, abortions are always done by someone, but today, a majority of abortions in the world are self-managed. Whether you like it or not, it's a reality. And interestingly, it's not doing badly because it's saving women from dangerous people. So I think if our organization had an ask, we should at least decriminalize abortion for the woman herself. That's not a part of the amendments, but at some point in time, we are going to have to champion these things. So let's start looking at contemporary contraception. In fact, almost every contraceptive that is available can be used by an adolescent. I'll just start off by saying that I can actually move on to abortions. The fact that an opinion has been widely held is no evidence whatsoever that it's not utterly absurd. This was big, you know, in the US, whenever there's a Republican government, and thankfully they now have a Democrat. Generally, the right wing tends to be very, very anti-contraception and abortion, no matter which country you are in. And they would push culture, abstinence. Let's face it, young people do what they do. Young people do not come asking for your permission. You either make them smart, like we tried to do when Dr. Hansotia was the president of Foxy, where we had a campaign for an entire year on empowering and educating the adolescent girl and give her information so she will look after herself. Of course, we would like abstinence, but is it practical? Not necessarily. Faithful, of course, and condom use, we would like to push it in a big way. But both you and I know that while condoms are great for infection prevention, they are not great for pregnancy prevention. So there is no doubt that condoms play a role. And every time I'm dealing with a young person, a young woman, she may not be an adolescent, I will always advise dual protection. Tell them use something for the pregnancy, something for your infection, and you are her partner. You are a co-conspirator. I will tell her, don't tell the guy you're using the pill, because then he won't want to use the condom. Guys don't like to use condoms. So condom 100% pill, and that is probably the best thing a young person can do to protect themselves. The only problem is that access for a young person of any method, particularly a medical method, is so difficult. I mean, to go into a store and even get a condom is embarrassing for a grown-up. Imagine what it would be for a young person. And in today's world, I believe this is something that should be available. Everything comes home. Parents won't even know, because Amazon sends so many things home to people's houses. I believe that's how contraception should reach people's houses and young people. Oral contraceptives, there is a theoretical concern that young people using oral contraceptives, you know how much we use for contraceptive and non-contraceptive purposes. It's a great choice, has a high efficacy. It has the same indications and contraindications. Dual protection gives better pelvic infection and STI protection. The only concern is when young people are not having sex very frequently, they become less compliant. And we need to find some way of making it more compliant. Studies, I don't need to tell people of you're all gynecologists how safe oral contraceptives are. And the 20 microgram pill probably is the pill that we would prefer. I always start off with 30. I use 30 for 3 cycles, and then I drop it to 20. My justification for doing it is that that there is a breakthrough bleeding in about 10 to 20% of a 20 microgram pill. If I started first, this person's confidence in the pill is gone forever. 30 works great. Then you go to 20 after 3 cycles. They love it. If it doesn't work, she can always go back to 30. Now, the problem here comes in because we want to do a detailed pelvic exam, breast exam, PAP, STI. Well, let's face it, this study in the Journal of the JAMA said that you don't need for prescribing oral contraception. It's desirable, but not necessary. And I think when you're dealing with young people, you probably have to go with a good medical history and a blood pressure measurement. That's probably all that they require. Then you can have very innovative outreach programs. Second generation still has a role to play, though I must confess I use them very infrequently. When we've got better stuff, when I've got 4th generation, why would I use 2nd generation? But I still use it when I want cycle controlled, abnormal uterine bleeding. And I will tell you how I select one over the other. 3rd generation, my preference, if I want cycle control and abnormal uterine bleeding, that's my first choice. Works extremely well. We've all used. Here again, I start off with the 30 micrograms, go to the 20 micrograms. But then in the late 90s, we all remember, at least those of us who were practicing then, there was a pill scare. People were very afraid of DVT. And they said, my God, the 3rd generation pills are causing more DVT. And that was true. But when they analyzed further, the risk with 2nd generation was about 6.5 to 12%. 3rd generation was 16 to 30 per 100,000 women. Okay. Compare this to the old doses of 80 and compare it to pregnancy of 150 per 100,000. So how do I decide my pill now? If there is a risk of arterial disease, I prefer 3rd generation. If there is a risk of venous disease, second generation levonorgestrel is definitely safer. So smoking, diabetes, hypertension, migraine, CVA, arterial, the other being venous. Okay, then come to the fourth generation. Obviously, most of us now favor this fourth generation. Why not? Patients were concerned about weight gain, bloating, and that, with this pill, thanks to the effect of drospirenone, which is an anti-mineralocorticoid, it has a great effect. It doesn't cause that. Plus, it has an anti-androgenic effect as well. So I favor this. If I want to control bleeding, I will usually start with the third generation, and after 3 cycles, bring them to a fourth generation. I mean, that's my personal way of working. Each one of us has our own way. And of course, what has changed is that when you use a 20 microgram pill, though it wasn't with the third generation, we now favor the 24/4 protocol. So I teach my patients extended methods where I tell my patients, you don't need to stop at 21 days or 24 days. You can go on for 42 days or 48 days. And my patients who don't want to menstruate every month love it. This 21 days is completely arbitrary, and there's history as to why that was decided. What about cyperotyrone acetate? For women with major hyperandrogenism, great. But I'm not comfortable with a 35 microgram pill if I have other options. So if it's a real bad case of hyperandrogenism, I start off with the cyperotyrone containing pill, but I very soon drop them down to a drospirenone 30 and then a drospirenone 20. And it seems to work just great. I have been using the Dynogest ethanol estradiol pill today, and you always find the niche and that whole group of patients where I'm suspecting endometriosis or I've treated endometriosis, considering that it does contain 2 milligrams of Dynogest, I usually favor this one. Gone are the days when you waited till the next cycle. That's where the disasters happen. Now it's always a quick start. Start the pill wherever she is in the cycle if you're reasonably certain that she's not pregnant. Okay, so that's what you do for women who have menstrual cycles or amenorrheic. And if you've done an MTP, please, day 5 post-abortion, where it is medical or surgical, get her onto the pill. We know, I'll just touch upon it very briefly, all of us use it for heavy menstrual bleeding, particularly in adolescence. An excellent application. It works extremely well. So I would use progesterone first choice, but I would put on the pill if required. Dysmenorrhea work great, particularly primary dysmenorrhea, which is not responding to mefenamic acid and the basic ways of doing it. You can put her on this for some time. Hirsutism, well, COCs have been recommended as first line. And this is then followed after a few months, if you don't have adequate response, with an anti-androgen. So I usually do a free testosterone and a DHT. And for a very young woman, don't forget to do a 17-OHP and don't forget to do a DHEAS as well. If there is a high DHT, I usually prefer flutamide, though I know a lot of people don't favor that. Spironolactone first choice, finasteride second choice, and flutamide third choice. And of course, regular monitoring of liver function in these particular patients. Now, one concern in young people is, what does the pill do to her bone mass? Because you are creating a kind of hypoestrogenic state. So our knowledge comes from post-menopause use, and they have shown that when you're using a pill of 25 micrograms or more, there's a net bone gain. At 20 micrograms, it is equivocal. You won't do any harm. And we don't have any pills below 15 micrograms that would probably create a problem with osteoporosis. Vaginal ring, great option, unfortunately not available. I think everything has to be on the table, maybe not in adolescents, but a lot of young women who have a problem with compliance. Now, one very, very classic group was women who work in the airlines. They keep going across time zones. Doc, when do I take my pill? Because I wake up in one country morning, reach the next country, my time is completely off. This was a great option. The patch is a wonderful option. I wish we could get that in our country. I have a few patients who get it from overseas. Great again for compliance, 7 days. Patch, use it for 3 or 4 weeks, take a patch-free week, and it's supposed to be giving you much better compliance than the pill and effectiveness. So this is, if there's one thing that's still missing in our country, unfortunately, we are losing the Nuva ring that's not available anymore, but the patch would be a great option. Progesterone only pills, progesterone only pills, great option, particularly for the young girl with migraine. Particularly when you have a young person where you're worried about using the pill and a DVT risk and we have had cases with problems. Okay, it's not like when you use a pill for in so many patients, all of us have seen cases with a cerebral venous thrombosis and stuff. So we always have to try and be as safe as possible. This has to be the desogestrel pill, and as I tell my patients, if it can be used in lactation, it tells you how safe it is. A long-acting contraception concerns were voiced in adolescence, but none of them have been really proved. In fact, they've shown that there are adolescents very often prefer amenorrhea and happier with amenorrhea much more than the older patient. And while there were concerns about bone density, I have used this in some groups of patients for many, many years, monitored bone densities. And if a woman has a reasonably healthy, active lifestyle, she's exercising, she's got a good diet, her calcium, vitamin D is fine, you should not have a problem. IUD, well, there is a place for IUDs as well in young women. I know, again, we say no IUDs before the first child. That's not true. The evidence permits you to use an IUD, either the copper IUD or the hormonal IUD. And I actually have some women who have out of choice taken an IUD as their first choice contraception even before the first pregnancy. So I think we need to open our minds and open our horizons. You get WHO has a wonderful app, which you have this kind of medical criteria for what to use, and that will tell you what you can and what you can't. And of course, the beneficial bleeding pattern of the levonorgestrel IUD we all know about. There was an experimental frameless IUD, and I wonder if that would be the adolescent IUD if we had to use one, which was levonorgestrel releasing, did not have a frame, but somehow not really come into practice. And finally, emergency contraception. Well, in the absence of anything else, I'm happy for young people to be using this. This they can access very easily. This comes over the counter. The traditional one with levonorgestrel and the newer one with ulipristal is really great. It's effective up to 5 days. In this particular case, of course, you have to understand that it is sometimes used too often. And every time a person comes to you today and says she's got a disturbed menstrual cycle, please ask whether she's taken multiple doses of EC. It's almost become one of those questions to ask. I have no problem with ECs. In fact, I believe they bring women to us, and then we can convert this EC user to a good, normal, conventional contraception user. And that's what our job has to be. Now, let's quickly look at some abortion protocols. We have some great technologies, simplified technologies today. And as Joseph Crutch has said, technology made large populations possible. Large populations now make technology indispensable. First trimester, we had a recommendation. Actually, Foxy made it first. Our government comprehensive abortion care guidelines, which we were very much a part of. See, the great thing of being a part of committees is you can influence them. So we decided mifepristone was 200, misoprostol 400 up to 49 days, and 800 up to 63 days. You may ask, why two different doses? All of us who use 800 micrograms of misoprostol know how much kind of rigors it creates, and sometimes it causes hyperpyrexia. If a woman is taking at home, that can be very, very scary. And interestingly, just look at the first column on the left-hand side, because that's the one applicable to our country. The WHO has now also recommended in its clinical practice handbook, which I believe each and every one of you should download on your device, and said that you can use misoprostol 400 micrograms up to 49 days, and up to 63 days, they've recommended 800 micrograms. They also have a regime for 9 weeks to 12 weeks, which is of course not being used as far as we are concerned. There's no doubt that we've given up on the 600 mifepristone, thankfully. Please don't mess with protocols. Mifepristone is 200 milligrams, whether it is here, whether it is suprime for mid-trimester, and I sometimes even use it for induction of labor in a non-inducible cervix. It's 200 milligrams. Misoprostol, Generally, the recommendation is 800. The vaginal route preferred, oral route less effective, though I usually use the sublingual or the buccal route, which works extremely well. Fine. So this is, and most of the use that we have now, all my patients have always taken medication abortions at home. They come to the clinic, they get their checkups, a few investigations, an ultrasound, sign the Form C, put her in the register, and then she goes home and takes the medication when she wants to. Right. Manual vacuum aspiration. I believe that this is the technology which backs up medical abortion and can see proud that we champion this. When we first started, I was the MTP chair in 99. And at that point in time, people had said MR is no use. We got this double valve MVA, which is as effective as an electric pump. And it's so simple. It's so easy to handle. It's so easy to keep and maintain. And Foxy, we did, of course, this was a study comparing MVA and EVA, and they showed they were comparable, but they said the blood loss was less with MVA, pain perception was also less with MVA. So we did a study in Foxy, a multicentric study, because we wanted a contemporary data, and we did 1,600 patients, 27 clinics. You know, that's how great our Indian practice is. We can do things like this so easily. I believe every society should. You can. Below 12 weeks, 8 weeks, 8 to 12 weeks, the beauty was that at that point in time, when most of us were using more anesthesia, 56% were done under sedation and paracervical block, extremely safety. And we actually did this for the government. Foxy did a project with the WHO. We trained doctors in 8 states to do MVA within 2 weeks, and that went into our national program. And I think we have some good credit for that. Now, one question comes with late abortions, because young people usually come late. And I get asked all the time, but you know, mifepristone, misoprostol are not approved in our country. So what do you do? Well, the government guideline says ethacridine lactate, which you and I know is not available. Way back in Foxy's guidelines in 2004, we had recommended 200 milligrams mifepristone followed by misoprostol. The Government of India guidelines, and this is again where we were a part of the committee, and it's great to be on the committee. We have a statement which says presently not approved method, though evidence from other countries shows that it's effective for termination, and the government guidelines have printed the entire protocol. So just imagine, on one hand, the government is saying it's not approved. On the other hand, the ministry guidelines have said 200 milligrams of mifepristone and go ahead with 400 micrograms of misoprostol every 3 to 4 hourly. And so I think we've got safety. You don't need to worry. You can definitely use mifepristone, misoprostol. We are trying to get approved, but even till it's there, we've got enough protection. And the Cochrane database completely agrees with us. These are 2 books I think you should download soft copies of and look at them all the time, particularly the one on the right. It's available online at the WHO website, and it gives you all these protocols. Finally, let's look at some special situations. Well, one situation which is not really relevant here is late abortions. I think all of us remember Nikita Mehta's case. I can put it here because it was in a court of law. I wish it hadn't happened. I wish someone hadn't gone to court. I get very angry when so-called activists go to court and ask for things which were given. Which gynecologist of my generation and even the next generation haven't terminated a birth defect at 28 or 30 weeks or an anencephaly? All of us did. Why do you need to go to ask the court and create trouble for ourselves? And now people think that every time there's a birth defect, you have to go to court. How many people have gone to court? 150. How many birth defects need a termination every year? Probably 100,000. So we've done disservice. Having said that, we had no choice. We were a part of the committee, and we've actually recommended this amendment. So hopefully once the parliament does its work and passes the amendment, we will be able to terminate an abnormality at any time. But what's bothering me again is they've put this very unreasonable requirement of going to a committee. And you know, committees don't meet. When committees meet, they are not very efficient, and we have to do something about that as well. This was conflation with the Pcos Act. This was an actual case. A Foxy member, she'd written me this lovely letter just after I'd finished as Secretary General. And she says, I'm sure you'll remember me. I'd performed an MTP on a young 17-year-old girl in Madhya Pradesh near Indore. A purview of Mtp Act. Unfortunately, her parents went to the police. The police actually had an FIR for this doctor. And that's happening even here in Mumbai. I've got some cases from Thane where authorities have kind of taken action. And she said, the court had given her, quashed the case, and she had thanked Foxy at that time. This is a problem. Now, we have no choice. You cannot do an MTP without informing. Unfortunately, sometimes you may be misled by the girl about her age, and then you become wary of conducting abortions after 12 weeks. I think if your paperwork is flawless, if you are honest, you should have no fear in doing what needs to be done for women and taking care of this. This was another case, very sad case. This doctor was actually imprisoned. This was 2015. He had been there was a trial. The guy had done an incomplete abortion. And the police came and arrested him saying your center is not MTP registered. Hospital registered under Bombay Nursing Home Act. See, you need to know, we had done this document. In fact, I had done this chapter with Dr. Salunki of Maharashtra government at that time. And that chapter actually said incomplete abortion, inevitable abortion, missed abortion, blighted ovum do not come under the purview of the Mtp Act and will not be recorded as an MTP. Please download this on your device and read it. It tells you how you can protect yourself when these things happen. Finally, I'd like to end by talking about stigma and how we have to fight stigma one individual at a time. Stigma is when, you stigmatize something, you make someone feel bad. Young people, irresponsible. Abortion, careless. They did not use contraception. It becomes us versus them. And we have to really, really stand up to stigma. And here I'd like to just end by quoting this one paper by Yanda, who talked about reproductive health and rights and said reproductive health programs should have an approach based on human rights. Do not be afraid. You are there for your patient and you have to be her champion. Resource poor women and young people face greater maternal mortality and morbidity because they resort to unsafe, inaccessible, and unaffordable services. And what can you do? Firstly, if someone comes with an abortion, welcome them for an abortion, incomplete or induced, welcome them. A lot of my colleagues say, but these women are doing medication abortions and coming to us with incomplete abortions. Nobody's bleeding to death. If you can treat a spontaneous incomplete abortion, you can treat her incomplete abortion. But look at the positive. She came to you and she didn't go to that quack who would put a stick in her uterus or in her vagina. Broaden the types of medical and health professionals are allowed to perform abortions. Here, I think our medical profession, I'm sorry to say, we've been extremely selfish. There aren't enough gynecologists and there aren't enough MBBS doctors to do 15.6 million abortions. We have to allow regulated mid-level providers, legally bound, because they were doing it anyway, and make sure that women get access wherever they are, in whichever village they are, because we are not there. And finally, we have to enhance training for abortion providers in simple techniques, standardized techniques. And I think it would be great if societies like yours also did workshops. I'd like to finally end by again quoting Yanda, who said, when rights to abortion and general reproductive health are restricted, those at greatest risk suffer the most. Young people come exactly under this. Young people are always at greatest risk. They don't have the autonomy. They don't have the finances. They very often don't have the confidence. They are afraid of stigma, and which is why they end up doing dangerous things. And for me, this is sad because not a single person, young or old, needs to suffer the consequences of unsafe abortion if we were only there to do whatever needs to be done at this very moment. Thank you very much. It's been a privilege.
Thank you so much, sir. That was a fantabulous talk. It's the A to Z of all of adolescence, sir. Wonderful. I'm so impressed, and I'm sure so are the delegates. If there are any questions, please do put them in the chat box. And if the chairpersons would like to make a comment, if Dr. Laul would like to make a comment, sir.
Yeah. Dr. Nozar, you have cleared our ideas very much. When to use fourth generation, when to switch to third generation, how to handle Pcos Act, how to do terminations. Then you have got, you have said that we have brought trouble on ourselves by going to court. That is a new idea, because one speaker which we have in the panel has said that refer all patients to us when we have termination at 24 weeks. So that was the advice given in one of the webinars. Now this is directly opposite advice. So then training of mid-level people to do termination, that again I think is a point to point from this talk. So all in all, there are some ideas which are very acceptable, is very practical, and especially regarding adolescent, I think if you follow them, we will have a lot of safe abortions and lot of means the ideas regarding treating PCOS, endometriosis, bleeding, when to which use tablet. Everything has become very clear to me after this talk. So thank you very much, Dr. Noze. But some of the points stick. I don't know what to say, whether to refer to 24 weeks or whether to do it that because once they come to your clinic and they start investigating, no, they are not like you. They are there to find fault with you.
No. So let me be very clear with this message as of now. There is an amendment, and once this amendment gets passed, this problem will be solved. My point was this problem need not have been created in the first place.
Yeah.
Dr. Lawal, I'm very confident that in your career, you have terminated many major abnormalities at any time in pregnancy. I have.
Yes, I have never gone for any permission
in our country who ever hesitated doing the right thing. I believe that if you have an anencephaly at 26 or 28 weeks, that is an obstetric problem. It's an obstetric indication. It is not an MTP. Why did someone have to go to court and ask for a permission for a 26 weeks when they could have done it the way we always did? Unfortunately, now, this is my problem. Activists create work in silos. They don't see what collateral damage is being caused. And why should you refer that 24-weeker to someone else? Because that's not how, I mean, what does that person have a different law? Is a different MTP Act function for that person? That person wants to take cases, collect cases and go to the Supreme Court. I showed you that one slide, I went through it very quickly. 1% of all abortions will be late abortions.
Yeah.
If you've got 15.6 million abortions in this country, every year there are about 150,000 women requiring a late abortion. How many have gone to court? 150.
Yeah.
We are being ridiculous. And can I also say this? And I say this very proudly. I think gynecologists are smart and sensitive. And we know what happened in Nikita Mehta's case. She had a spontaneous abortion.
She had a spontaneous abortion. Yeah, everybody knows she had a spontaneous abortion.
She had a spontaneous abortion. And my patients, even
Sir,
today,
capital, spontaneous in capital.
my patient, even today, and I'm confident, may have a spontaneous abortion.
Correct.
Be there for your patient. Okay, we are not trying to bring attention and limelight because it doesn't work that way. Anyway, that I'm hoping that when the amendment gets passed, that problem will be solved with some difficulty because we will have to go to a committee. If we can scrap the committee and we are trying to do that, that will be a great idea. Mid-levels, please understand there are WHO documentations which say mid-levels work. What is the alternative? You know, we were once asked by a secretary in the government, Dr. Sheria, वो जो lady है ना village में जिसके पास कोई access नहीं है, where there is a primary health center which does not have an MBBS doctor, where does she go? Why does she risk abortion on her own? Give women an alternative. And I would rather take that nurse and train her and teach her only medication abortion, only early medication abortion, diagnosis of pregnancy, recognition of complications, when to spend. I keep getting two things. But women, nobody is bleeding to death. The deaths due to unsafe abortion in this country have come down because of medication abortion and because women have self-managed in a big way. Number one. Ectopic pregnancy is the next big fear people create. Baba, you look after ectopic pregnancy in spontaneous conception. In fact, here, if I train that nurse or whoever, I would tell her that if this woman does not bleed within 24 hours, please refer her to a higher center. You will actually prevent an ectopic pregnancy from rupturing. So we have to now start thinking about women and public health, and nobody is going to threaten our practice, because let's face it, these women who are doing it themselves are not coming to us. So I just feel as an organization, we are going to have to revisit. We were the champions in Foxy. We let women down. I think we need to get back to it at some point in time, and we need to have this open discussion. Nobody wants to talk about it because it becomes very political and very whatever, IMA, and everyone gets involved. No, it's about women. It's not about us.
Well said, sir. So there are two questions in the chat box, if I may just put them to you. First question is from our past president, Dr. Rajneesh Patel. How about routinely asking for Aadhaar card copies to safeguard the gynecologist in case of young girls if they are lying? If they are lying about their age, do you think it is a wise practice to ask for Aadhaar card?
Don't start a practice that the law does not require us to start. So I won't say yes, I won't say no. I know that a very dear friend of mine, Atul, his past assistant, recently was arrested because she did a termination, and the girl herself told the police that she lied, and she's out on bail. It's really sad, and it breaks your heart. uh, are we going to take a Aadhaar card for each and everything? This is never what it was meant to be. Otherwise, what about any other patient who comes to you who might be misrepresenting herself? What about any patient who comes to you for anything who might not be telling the truth? Okay, so I don't know. As far as I'm concerned, the law needs her to fill Form C. In Form C, she writes, I so and so, age so and so, and she signs against it. And for me, that's a self-declaration, which is quite adequate. Now, will this sometimes go wrong? Yes, that's where you probably need to be judicious and use your common sense. And remember one thing, Mtp Act has a Section 8, which has not been utilized enough. It has been. Section 8 protects you from any criminal or civil legal proceedings if you have done your documentation, paperwork, and you've done it in good faith.
Sir, I think it will be a good clinical practice to have Aadhaar card, even if it is not mentioned in law.
So that is, I think that Dr. Lawal, I'll leave that to the judgment of each and every practitioner. I can't.
Because when they start investing, no, the Aadhaar card will help us.
I agree.
Okay, there's one more question, sir. Married girl below 17 comes for ANC registration. Should the concerned doctor inform the police under the POCSO Act?
As far as the POCSO Act is concerned, you're bound to inform the police. And that's the anomaly of this act, where you have got so many women in our country who are having babies before the age of 18. And we are not just looking at the city of Mumbai, where also it happens. We are looking at our country as a whole. But if you go by what the Supreme Court said, the Supreme Court said a married girl is covered under the POCSO Act just as much as an unmarried girl is. I think we need to probably again work to get something done with the POCSO Act. We have to find a solution. I always believe if you don't find a solution, you are a part of the problem. And our old law of 16 as the cutoff was for me very reasonable, because under 16 consent is a little, okay, it can very often be coercion. Between 16 and 18, the girl usually has confidence and consent, with the understanding that we be very sensitive, very watchful, and report anything that we suspect might be in the form of abuse or rape. But we are doing a lot of injustice to young people. Like I said, I've got so many cases informed to me, and many of them from around Thane, where the authorities have responded different ways. Some of them register a 0 FIR, some of them go and arrest the boy. And it's not just about the doctor, it's even about the young people themselves. No wonder they are not coming to the facilities. Where are they going? Have you ever asked ourselves that question? What are they doing to themselves? Do we not want to make things safer for them, or do we want them to force them to go unsafe?
Unfortunately, I think, sir, the bureaucrats don't realize how much disservice they are doing to the population in general.
Well, I am told that there are sensitive and police officers, there are insensitive, and then there are corrupt. So there are all kinds of people we have to deal with. That's the problem.
Yeah. One more question from Dr. Sandhya Saran, our president-elect. What is your most preferred contraception in athletes, tennis players, swimmers, etc.?
So like one of my teachers had once said, the best contraceptive is the one that the woman is willing to use.
I agree.
Okay, so here are these people, particularly if they are people who are now, many of these women will tend to have hypothalamic disturbances and hypothalamic amenorrheas,
Yeah.
right? In this situation, well, basically you can use any and all contraceptives. Long acting reversible contraception wherever possible.
Yeah.
I think we've underutilized that.
Right.
And I love the fact that I have choices. Injectables are great, and today with the new injectable subcutaneous, it's really great. But a woman has to be willing to accept the fact that she will have menstrual disturbance and a high incidence of amenorrhea. Some women love amenorrhea.
Yes, sir.
The
So
intrauterine.
in my population, I'm using very extensively because they have a lot of reservations against the IUD, and I have women using for 10 years, 15 years. They've been using, and they're so happy with DMPA injections.
Correct. And part of the reason is, and I know this from my family planning association relationships, that they are not, nobody finds threads, nobody finds packets. They come for a health checkup and take an injection and go back, and they have complete control over their autonomy. And of course, in India, when you don't menstruate, it doesn't mess with your religious responsibilities, no matter which community you are. Except
Yeah.
for Christians, all communities have problems with menstruation, which is so sad, which is something we have to do away with. So that I use the levonorgestrel intrauterine system a lot. I still think that the multi-load 375 is a great option. So I use that in a woman who does not want her periods to be disturbed. And well, recently I've started using the implants. Nuva ring, the vaginal ring was good, unfortunately not available now. So I have been starting using more than a few implants if someone's worried or someone's doesn't want something in the, or a young girl where insertion might be difficult.
Okay,
So
we
I'd
have
probably go long by one of the LAC methods.
okay. One last question, sir. Any special law for MTP in pregnancies caused by a live-in relationship where marriage is not performed? It's a live-in relationship. It's from
There's a
Dr.
law for
Yasmin.
MTPs and there's a law for abortion. A woman who is in a live-in relationship or in a married relationship does not need the permission of her partner, married or unmarried, to do what she wants to do if she's over the age of 18. In fact, it bothers me when people start looking for spousal consent. Not only
Right.
is it not necessary, this is the one consent form in medicine which does not even have a witness signature.
Yeah.
It only has the woman's signature. In fact, I would go one step further and say, just extending it forward, that you don't even need the spousal consent while doing a permanent sterilization. And I don't know why we look for spousal consent when we are doing ligations, when I've never once known about a single person asking for spousal consent for vasectomy.
Yeah. That's true, sir. That's so true.
And the
But
law
then,
doesn't
sir, what
no,
as graduates, what we were taught is there is another law which says that if the spouse, if the rights of the spouse are going to be compromised, the spouse's consent is required. So ideally, for vasectomy, the wife's consent should be taken too.
exactly. So there is no law. In fact, if you read the government guidelines of the Ministry of Health and Family Welfare, there is no spousal consent. The only one sticking point is where in a court of law, this has been treated as cruelty when giving a divorce. You know what? If that's what it's coming down to, I think the couple is better off being divorced.
I know. Okay, there's two questions in the chat box. Married girl under 17 comes for ANC check. Oh, Dr. Vatsala Vaidya, this question already you've taken up, sir. So I think we are done with the questions. So I think now we can proceed with the panel discussion. While sir is still available, we'll
Yeah,
quickly go through the...
I've been getting knocks on the door. I think they've given her a position. I will try and see if I can finish off.
Please try to get back, sir. Try to get back to us. So I'll now request the chairperson for the day, Dr. Ajay Kumar Bhaskaran, to please introduce the panelists for today. Can we have the back end? Zoeb, can you please show the slides?
Yes, sir. So
Good afternoon. So today's moderator for the panel discussion is Dr. Supriya Arwari, MD DGO, FCPS, DNB. She's consultant obstetrician, gynecologist, and infertility specialist. She's trained in MD at KEM Hospital, Vadia Maternity Hospital. She's practicing at Supreme Hospital, Bhiwandi for the past 20 years. Joint Treasurer and Chairperson of Adolescent Health Community of Thane, Obstetric and Gynec Society. Chairperson of Adolescent Health Committee of Association of Maharashtra Obstetrics and Gynecology Society. She has been awarded Anandibai Joshi Award for material service by female doctors. And overall, she has won the title of Mrs. Iron Lady in Medi Queen Mrs. Maharashtra Beauty Queen Pageant 2020. Welcome, madam. Next slide. Our panelist today is Dr. Ashwini Bhalerao Gandhi. She has done MD, DGO, DFP, FCPS, DNB, and FICOG. She is consultant gynecologist at PD Hinduja Hospital, Mumbai. She is President Mumbai Menopause Society from 2019-21. She is Vice President of the Federation of OBGY Society of India 2013. President OBGY Society 2012-13. She is Chairperson of Adolescent Health Committee of FOXI from 2004 to 2008. She is ex-associate professor TN Medical College and Nair Hospital. She is secretary the Journal of Obstetric and Gynec of India. She is consultant gynecologist at the Valva Clinic, first of its kind in India at Hinduja Hospital, Mumbai. Next, please. Our next panelist is our dynamic president, Dr. Rajiv Lal. He is MD of Gynec. He is a gold medalist. He is president Thane Obstetric and Gynec Society. He is honorary professor at Rajiv Gandhi Medical College, Kalwa, Thane. He is the director of Renukon Nursing Home and consultant OBGY for last 30 years. He is a half marathon runner and avid singer. Welcome, sir.
Thank you, Dr. Ajay.
Next slide, please. Our next panelist is Dr. Alka Godbole, madam. She is MD, PG, DMLS. She is medical director at Akshay Surgical and Maternity Home. She has presented papers on various subjects in regional and national conferences. She is the winner of Thane Gunijan Award, past General Secretary of TOGS and past Vice President of TOGS. Welcome, madam.
Ajay sir, I think that will be all because Datta sir will not be able to join us. He had some urgent work.
Yeah.
So thank you, Zoeb. And thank you, Ajay sir, for the kind introduction. And once again, on my behalf, I would like to invite all the panelists to join this session. Special thanks to Ashwini Gandhi ma'am for giving her last minute consent to stand in for our panel. Thank you, ma'am. It's a great honor to have you. And I think now we'll start with the panel discussion. I'll just be sharing my slides. Okay, so welcome TOGS. The topic for today is something that we are practically using every day, and we would like our panelists to give us some real good crisp take-home messages as to the use of comparatively newer drugs in the adolescent age group. And I welcome all my panelists once again. Since it's Valentine's Day, let me begin by wishing a happy Valentine's Day to all my dear friends from all categories, the ones who are dating and the married ones who are accommodating.
She's always too good.
Thank you, sir.
Yes, sir.
You always bring a smile.
Thank you, sir.
I hardly smile, but
so nice to see you beaming, sir. You look so
Yeah.
sweet when you smile. So the main drugs of focus today are myo-inositol, cyprotrone acetate, and dinogest. And when we talk about myo-inositol and cyprotrone, we definitely are talking about PCOS. Of course, there are other uses that we will try to bring out today. But first and foremost, these are the drugs which are going to be talked about when we talk about PCOS. Now, these are the guidelines that have been given, the various guidelines. We follow the Rotterdam, now the newer guidelines have come, NIH guidelines have come, the AEPCO Society guidelines have come. The question to the panelists, first question here today is, what are the diagnostic challenges that you face in PCOS in the adolescent age group, and whether any different criteria are applicable to them? I think we'll start with Ashwini, madam. Madam, you have done extensive work on adolescent healthcare. So would you like to take this question, that what are the diagnostic challenges that you usually face when we are dealing with adolescent age group?
Usually what happens is that when a girl who is in pubertal age group comes to us with irregular periods, the parents have maybe heard somewhere that PCOS is very common, and then they are worried whether the daughter is having PCOS or not. So this is very confusing for the parents and also sometimes for the gynecologists. And what we have to always remember is that from 2 years from menarche, we should not label her as a PCOS. And even it is better to avoid doing sonographies if possible, if you are not suspecting anything else. Because on sonography also, the features like PCOS like ovaries will come, and again she will be unnecessarily stigmatized. So it is our duty to explain to the parents and the girl that irregular periods are very common immediately after menarche, and maybe after 2 years also if they remain like that, and then other features also start, then we can say that yes, maybe she is having tendency of PCOS. But we use the same criteria as used for the adult PCOS women, and there are no separate criteria which are there for the adolescent girl as such.
That's right. Very true, ma'am. Very true. This is just a quick slide about differential diagnosis of girls coming with irregular periods and signs and symptoms of hyperandrogenemia. Now, the second question I'd like to put to our panelist, Dr. Alka, madam. Madam, what are the specific things that you would like to do when you're evaluating an adolescent young girl who you suspect could be PCOS?
Yeah, main thing just now, just like Ashwini madam has described, that a thorough history should be taken from the patient and the parent, means the mother. And thorough physical examination should be done before you label her as PCOS.
Correct.
So in thorough history, you should ask when the menses has started, or means the age of menarche, year of menarche, and then how many months she is having amenorrhea. Then is she having any family history? Because sometimes, or 50% patients are known that they know that my mother is also was also having the same problem. So many a times this happens. And then the weight, first and foremost, whenever the patient enters inside, we see her weight. She is obese or lean, both are there, but mainly these patients are very, very obese. And if we look at the facial contours and their development, then we should look for acne, history about hair loss. Many times they give history of hair loss. And menstrual and reproductive history, reproductive is not so common, but menstrual history, they always tell that to start with, menses are okay, were okay for few months. And then this generally, whenever they enter in 9th standard. So according to me, I think stress is the main factor for them, because whenever the study increases and there are so many classes, tuitions for them, they start losing this confidence in, and they are not worried, but their mother is worried about their amenorrhea. Many a times 6 months, 7 months amenorrhea is there. And family history of hirsutism, premature balding, family history of diabetes is very essential to ask.
Correct. Very well said, ma'am. Laul sir, next question to you is, what particular investigation? Now, there is a host of investigation that can be done in a girl who you suspect of PCO or who has come with irregular menses. Practically, in your practice, can you tell me a couple of few investigations that you must do before you start managing this girl?
Now, if she has got hirsutism, then I think serum testosterone level is a must. We will have to do serum testosterone level here. And of course, they have said that USG is not recommended, but I think there is no harm in doing an abdominal USG, where we will get the idea about the uterus, ovaries, and also if there is any ovarian pathology, that also can be ruled out. Yes, we cannot label that patient as PCOS based on USG findings, but it can be taken into consideration with other factors such as hirsutism and the menstrual disorders. And
Correct.
if we are finding that the hirsutism is of more severe category, then of course we will have to investigate her for congenital adrenal hyperplasia also. And of
Right.
course, TSH and prolactin will also help us, as Dr. Shashank Joshi was telling us that uh, remember hypothyroidism, and hypothyroidism means prolactins are they are all related together. So I think this will form the base of investigation along with the detailed history, where we'll get a complete idea that we are dealing with a case of PCOS.
Correct. Very true, sir. Very true. So
Supriya,
just
PCOS is the disorder of diagnosis of exclusion.
absolutely, ma'am.
So
Yes.
we have to remember that we have to rule out other problems before we say that this girl is having PCOS. So investigations, some investigations, as said, told by Dr. Laul, they are important.
Yes, sir. Yes, ma'am. Especially ultrasonography, although the definitely guidelines say that we should not label her as a PCO based on an ultrasound below 8 years of her menarche. However, it will always help in ruling out other pelvic problems like an ovarian cyst or some ovarian masses or any other pelvic pathology. So I think an ultrasound also should be done, although we should be careful about, interpreting the report. Especially sonologists often write one side PCO, questionable PCO. So we should be very wary about interpreting. So just to sum up what our esteemed panelists have said, that definitely PCOS poses a challenge during the adolescent age group because it's a pubertal axis which is, trying to develop. It is still undergoing maturation, and therefore all the possible problems that occur in the PCO can be transiently present in a young girl who's just coming of age. The adult diagnostic criteria may or may not be directly applicable, and these are the guidelines that are there, that below 8 years of post menarche you cannot make an ultrasound diagnosis of PCO, and within 2 years of her menarche we should not label her as a PCO, because up to 2 years her pubertal axis is still evolving, and she may still have some changes coming up, and after 2 years many of those girls will have regular cycles. So exclusion, of course, like madam has very truly stressed, that it is mainly criteria for exclusion. Madam, any high risk group of adolescent whom you will be particularly watching out for as cases of PCOS, that they are more likely to develop PCOS? Ashwini ma'am?
Yes, definitely. We have to ask family history of diabetes, then even a family history of any mother or elder, maybe the daughter, means a sister, whether she has any PCOS, and irregular period history. And it is seen that the families where there is coronary problems or baldness history in the male, even with like a father's side, etc., and
Correct.
diabetic history, the same families are prone to have PCOS. So definitely we should ask something in the family history, so that even the mother also feels that it is not just happening, there is some reason behind it. Otherwise the mother will keep on asking that why this is happening, why PCOS is there, why PCOS is there. So if we give this background, maybe she feels that we cannot do much about this family history, but yes, definitely lifestyle wise we can do many things.
Correct. Alka madam, we all know that the mainstay of management in a PCO girl, young girl, is first and foremost lifestyle modification. Now you are a great champion of healthy lifestyle, yoga, the works. So what would be the advice that you would like to give these young girls about lifestyle?
Yeah. First and foremost advice I always give to these patients is lifestyle modification. About doing yoga, you learn yoga, you do skipping. That is the cheapest exercise available. And every time they go on complaining, no, madam, because of lockdown, we couldn't do anything, but they could eat so many things. So that was the main problem in this era, lockdown era.
Tell me about
first,
it, ma'am.
I always tell them, forget about lockdown. You can't go if you don't, you are not able to go outside, you have to do at least cycling down your building or skipping. Skipping is the main, and I think I believe that each and every school should have yoga classes at least once a week for each and every student. That is my recommendation. So whenever I go to school visits to give lectures on adolescent health education, I always tell their headmistress that please start yoga, appoint one yoga teacher. I know so many. So this is the main lifestyle modification. And second, everybody knows, we always tell them avoid junk food. Even one of my patients yesterday only, she came and told me, madam, जब से आपने बोला ना कि बाहर का कुछ खाना नहीं, 2 महीना मैंने स्ट्रिक्टली वो ये किया, फॉलो किया और मेरा वजन कम हो गया, और ये महीने में तो विदाउट टेकिंग एनी medication I got normal menses. So that was the main certificate. But
so nice.
That's what I want to tell, that you can give this example to other girls. And I told her, this is not the end. You have to maintain this. Because once they start going again from the old bad habits, again this starts.
Correct.
So lifestyle modification, खाली lifestyle, what is lifestyle? एक patient ने मुझे बोला, she was asking me, अरे I read so much on this thing, Google and all this. Madam, what do you mean by lifestyle? So when I told her simple exercises, at least use lift, don't use lift, use staircase. Where are you staying? Second floor or third floor, you have to use stairs. Correct. That is the simple, cheapest exercise available.
Correct.
So, hello, Dr. Supriya. Yeah. I think along with that yoga and walking, if some amount of weight training is also done, that definitely helps in managing this PCOS.
Yes, so, sir. Truly said like an athlete. I'm sure all our viewers know that Dr. Laul is an avid marathoner and a very, very fitness freak.
Because after some time, yoga can be less challenging where your own weight is concerned. So, thoda sa challenge lo, thoda sa weight training karo. That will help further. That means, of course, do yoga, of course, do walking, and also do weight training. You will have better. You may not lose in kg, but you will lose in inches, and those inches and that fat burning will help in lowering testosterone levels, and of course, will help you in every way.
Yes, sir. So my next question, sorry.
Priya, only one point I wanted to mention.
Yes, ma'am. Please.
That if one stops eating outside and also starts sleeping 1 hour more, automatically the weight will go down 1 to 2 kg per month.
Wow.
So maybe the adolescents, they don't even sleep properly because of the late nights and exams and studying. They don't realize it, but ultimately it is having bad effect on the weight.
Madam, with COVID now, there is a binge watching of Netflix all night long, and people are sleeping at morning 7 or 6 o'clock and getting up in the afternoon. All their schedules have gone for a toss. So this is I totally agree with this. Next question, Dr. Laul. Now, primarily, most of these girls have some problem with cycle regularization. So what drugs would you recommend as first line, and for how long will you recommend those drugs?
I think for menstrual regulation, of course, the first and foremost, we will always emphasize on this lifestyle modification. That means for everything, first going for lifestyle modification. If that is helping, then you may not need pharmacological therapy. But if that is not working, then the options are combined OC pills are there, then metformin is there, and then depending upon the case, that if it's still not responding, then COCs with metformin, and so on and so forth, the list goes on. But I think for menstrual regularity, combined OC pills are extremely good. But by 3 months, I think she will have menstrual regularity, but associated hirsutism and acne, at least the pill will require to be taken for 6 months for that to help.
Correct. And we need to also counsel the patient that, especially the mothers, that it can happen that the cycle regularization, by the time we finish with the drugs therapy and we stop drugs, and after maybe 2 to 3 months, she may go back to her irregular menses. There is another thing, because that is why otherwise they go on doctor shopping, because from one place they took 3 months of OCs, then they didn't get, they again the periods became irregular, then they go to another doctor. So they go from door to door. So they need to be counseled at the outset. It can happen that the cycles may not be totally regularized. That would be an important part of it. Yes, ma'am, you want to make a
Supriya,
comment?
it is important to tell the parents as well as the girl that they, even if they get periods 4 times in a year,
Yeah,
it is all right. It is okay.
Correct.
It is okay.
They need to be
because that
sensitized about that.
obsession to get monthly period in PCOS girls, it's not feasible and possible. And yes, we can give her COCs, but we can't keep on giving her COCs.
Correct.
And that's why only withdrawal, if required, every 2 months to 2.5 to 3 months.
Yes.
With very, what you say, weak progesterogens, which have very less side effects like dydrogesterone. Maybe that is the only way out, and continuing this yoga and exercise and weight loss, and if required, metformin. Maybe that is enough for a long-term basis.
That's true.
Because OCs we can give maybe short-term, 6 months, 1 year, 2 years. We are not going to give her lifelong.
Correct.
So then we have to shift over on these other drugs.
Right. Now, madam, a girl who has come with PCOS, she has typically impaired GTT, raised testosterone, her TSH, prolactin are normal. She has a mildly impaired lipid profile. And what we are actually now dealing with is a case of PCOS with metabolic syndrome. So as we know that metabolic syndrome is linked to a host of medical disorders like obesity, lipid abnormalities, impaired GTT, type 2 diabetes, hypertension, hyperuricemia, and increased risk of coronary heart disease in the future. So the next question now is, what is your opinion about the use of insulin sensitizers in management of PCOS? So first, would you like to comment on metformin, madam? Ashwini ma'am, you were talking about the use of metformin.
Yeah, definitely, especially when you are seeing full-fledged, signs are there, like acanthosis nigricans is there. Then also, if you have done GTT, the endocrinologists say that if the acanthosis are there, you don't even have to do GTT. But yes, fasting post-lunch we should do, because we have to rule out frank diabetes. This is not only we are worried about the pre-diabetic condition, but we should know whether she is not having frank diabetes. And obesity is there, history of diabetes in the family is there, then it is a very good idea to give her metformin. If you feel that she is into the mild to moderate group, then we can only give her after dinner metformin. That is also enough. Because the first thing which is going to be elevated is the fasting blood sugar. Post lunch is not going to go immediately up. So in pre-diabetic condition, only the fasting blood sugar will be around 100 or little bit 100 plus. So these are the girls who require metformin only after dinner. And again, then you start with other activities like exercises, diet control, etc. So that we are not giving too much of metformin. But if she is in the moderate to severe group, then yes, then we can give her, or GTT is abnormal, then we can give her metformin 500 milligram 3 times a day. So we can shift from after dinner to after breakfast and after dinner, and then last thing we can add is after lunch.
3 times, yeah.
So slowly we can go like this. And I'm sure that if you don't explain to them that metformin is not used only in diabetic, it is used in pre-diabetics, then only they will take. Otherwise, the parents will feel that we are giving diabetes medicine to her. And my daughter doesn't have diabetes. So she's going to change the gynecologist. Because they don't want the daughter to be labeled as diabetic. They feel that because we are putting her on metformin, now she's diabetic. So there is lot of counseling which is required, and sometimes even visit to endocrinologists who also will convince her that metformin is really good for her in many ways, and even it will avoid fat deposition in the liver. So many other things which will be avoided, and even it will improve hirsutism. Means hirsutism will become less. Maybe with this counseling by the gynecologist and endocrinologist, the parents will agree to continue with metformin. Otherwise, they are going to stop metformin in maybe 1 month and 2 months.
Very true, ma'am. Very true.
Yeah.
Ma'am, Alka ma'am, Now we come to the role of myoinositol, which is our focus of this particular talk. Now there are host of products available: myoinositol, NAC, DCI, berberine. So what is your opinion about the role of these insulin sensitizers in PCOS management?
I think, according to me, there is a big role, major role is played by myoinositols, because I have one objection for giving metformin. Though it is cheap, it is having more side effects than myoinositol, because myoinositol is a product which can be synthesized in our body also. It is already synthesized, but there is a deficiency. So according to me, myoinositol is the best medicine, because it regularizes also many hormones, just like insulin, TSH, FSH, and it decreases cholesterol. So many functions it is creating. So if you see, myoinositol 2 grams per day is the best medicine for these, because it is available orally, mainly in so many forms, that powder form, capsule form, and it's very easy. Only thing is, it is little costlier than metformin. So I always tell my patients that you have to take at least for 6 months. First, I give for 3 months, then, and with COC pills. And then when it is controlled, she gets menses, then I keep them only on myoinositols. 2 grams per day is the best. Myoinositol plus D-Chiro, that is the best combination.
Very correct, ma'am. These are a few studies that have shown the definite advantage, and especially of the what we need to stress is the right dose of giving myoinositol. Laul sir, would you like to make a comment on what dose you practically use, and for how long do you use these drugs?
I
3
think
months, 6 months, 1 year?
lesser dose, uh, if the lesser dose is given, the benefits are not good. So
Correct.
if we are giving 4 grams for, I think, 12 to 16 weeks, the benefits are much more. That means there is improved glucose tolerance, glucose handling, and of course what madam said, that combination of myoinositol and D-chiroinositol, myoinositol for insulin, increasing insulin sensitivity, for D-chiro for this is anti-androgenic effect. So combination of them will help in controlling both the aspects, that is the insulin sensitive aspect and also the anti-androgenic effect. So if we give it for 12 to 16 weeks, I think the benefits will be more visible, but they have got only minor benefits as far as this metabolic cardiovascular health is concerned. And I think for weight loss, I think the lifestyle modification, I think is to be emphasized
Absolutely.
upon more rather than this myoinositol and D-chiro.
Absolutely, sir. So this is again a study where they have increased the dose of myoinositol to 4 grams, and they have found that the plasma triglycerides are reduced by 52%, plasma insulin is decreased by 36%, and they have concluded that definitely at this dose it is going to have improved glucose tolerance and glucose handling. So definitely it is very effective in the correct dose, given in the correct dose. Now, according to you, which of the this is panel open to the whole floor. Like I mentioned, that Mayo is there, DCI is there, NAC is there, berberine is there. What are your personal preferences from among all these various preparations? Ashwini, ma'am?
As far as adolescent girls are concerned, I do not prefer myoinositol. I would like to keep it, if at all they come later on with infertility.
Okay.
I do have lot of faith in metformin.
Right.
And as a first dose, I would go ahead with metformin only. And in few cases, if the girl is not tolerating metformin, and as Dr. Alka also has said, it is very expensive. It is not less than 1,000 rupees per month.
Yeah.
So a school going girl, so many classes are going on, so many, as it is, the parents have to spend so much, 1,000 to 1,500 to spend only on tablets for PCOS. I think it is may not be cup of everybody. So
Right.
I would still go ahead with metformin. and not go ahead with myoinositol and D-Chiro because of really they are very expensive.
Okay. Love sir, if at all you use it, what is your preference?
See, first I will again emphasize lifestyle modification. If that is not working, and as madam said, try metformin, still not working, then we can use myoinositol. And I think this combination is, I think adolescent is not going to take this dose of 4 grams daily. I sometimes I feel that is impractical. The dose, that much dose, and also the chiro, if you add to that, I think compliance from the adolescent girl would be difficult to achieve. So I think if older age group, that means if the adolescent is around 17 or like that, I think then these things can be prescribed and they will help. For young girls, I don't think this is a good option.
Okay. As such, they are safe, though of course they are quite expensive. Conclusion, if at all to be given 4 gram or to be avoided in the young age group. Now, since we are talking about the cost, I got these lovely slides whether there are any natural sources of myoinositol.
Yes.
So, madam, would you like to make a comment?
Yeah.
Alka ma'am.
There are so many citrus fruits like oranges, kiwi, papaya. They contain lots of myoinositol. Then next comes so many types of beans.
Correct.
So many nuts and so many grains. Different grains are available. So whatever we will prescribe with mayo, I always tell them that this is available in homemade food also.
Absolutely.
If you eat homemade food rather than junk food, you can get myoinositol directly without less side effects, and there are as such there are no side effects I haven't come across because I am a myoinositol prescriber only.
Okay.
Yeah, because I never give only for my paper. I gave to I think 170 girls. I gave metformin, and for 165 girls, I gave this thing myoinositol. In both of them, same results I found. So I am a great prescriber of myoinositol.
Wow.
But if these results are same, then why not prefer metformin?
Yeah, that is okay.
Is
But
there is much
those,
cheaper option? No, if the
no,
results are
that is
same.
okay. Those who can afford.
But where is the question of affording? If
Yeah.
metformin is available and they are
Because
taking it, where is the need?
those girls those parents who are they themselves are on metformin, they always make a objection. That's why I started using this mayo.
But your study shows that the benefits are same. So if myoinositol would have given better benefits, better compliance, then something to recommend it, no? Something to only thing I think is the side effect that's what I'm saying.
Yeah,
I guess it's a matter of preference also.
Yeah.
So this is a chart of myoinositol rich foods. If our viewers would like to recommend to their patient, this is like a high myoinositol diet, which is giving 5 grams of myoinositol. That is a really creditable point. So now we will proceed with the next question in the list. We will now be talking about managing the hyperandrogenism in adolescence. Now, this is a very, very touchy subject, and young girls are extremely sensitive to this. So, Laul sir, would you like to begin? How would you, try to manage a girl who has come to you with hyperandrogenism?
So
we are talking about severe hirsutism, severe acne.
So first we have to find the cause. That means the commonest cause is, of course, for mild hirsutism is PCOS, and other causes need to be investigated before we know how to treat this patient. So I think the hair pattern that score is there, Freeman-Galway score is there to determine the degree of hirsutism. If it is 8, mild hirsutism, more than 15, severe hirsutism. So, and also distribution of the hair, male pattern end hair is there. So once we have diagnosed that she has hirsutism, then she has acne, then of course we will have to do investigations such as serum testosterone levels will have to be done, And if the serum testosterone levels are less than 150, I think we can safely say hirsutism. But if it is more than 150 on very high side, then that is not there in PCOS. The other causes such as congenital adrenal hyperplasia, which are not rare, will have to be considered. Then also other lipid profile and fasting glucose will also will have to be there. So and depending upon the menstrual irregularities and combination of all that, so we will come to the diagnosis that this is a PCOS case with hirsutism.
Correct, sir.
And depending upon that, the first line would be the COC pills with drosperinone will be of helpful in this type of patient. That means the spironolactone derivatives will also be there in it. Low dose of estrogen will also be there, and it will help in controlling both acne and hirsutism over a period of time.
Correct. So the role of anti-androgens definitely is there in girls with hirsutism. Ashwini ma'am, what is your opinion about the use of cyproterone acetate in these girls? How long would you use? In which particularly cases you would like to use?
Acetate has a very good role, especially to reduce this hyperandrogenism, because it will suppress the testosterone level. And because of that, the overall features will go down, like acne and hirsutism definitely, and it will regularize the cycle. Plus, if at all the girl is sexually active, then it will also provide her with contraception. So definitely it is a very good choice. And I have been using this oral contraceptive pills with sapropterin acetate definitely for a very long time. And we cannot say that how long to give. That is a question, $1 million question. But definitely if you give only for 2 months and 3 months, even hirsutism will not go down, because it takes 2 to 3 months for the pill to start acting as an anti-androgenic agent. So she will have to definitely use it at least for 6 months onwards. And then as soon as she feels that the hirsutism growth has gone down, this is a time, if she's 18 years plus old, then she can try for laser therapy. Because ultimately that is the only solution for the hirsutism, unnecessarily hair growth. Because we are not again going to give her this sapropterin acetate or any other OCs for a long time. We can give maybe 1 year, 2 years, 3 years, not more than that. So ultimately, she will have to go for this cosmetic laser therapy, etc. So that in future, again, if there is a disturbance of the hormones, at least the hirsutism will not bother her.
Correct. Alka madam, what is your opinion about cyproterone acetate, or what is your experience?
I have very good experience with this, because so many girls are complaining little mustache, little hairy growth on face. They are very well with this Diane 35 or cyproterone acetate. I always give them for 6 months. First only visit, I tell them that you will have to use this for 6 months. If you break it, otherwise there is no use of using this. Again, you will have to go for this. So it's very good.
Correct. Very right. Laul sir, any comment from your side?
If this cyproterone acetate is not working at low levels, I think more the dose can also be given when we are facing the severe levels of hirsutism. That will also help this patient. So if we can start with this combination of OCA with cyproterone acetate, and after then shift to the other type of OC pills. That means OC pills with drosperinone can also be shifted.
Very true. Any of the panelists have any experience with using GnRH in adolescent group? Normally, we don't prefer it in adolescent
Not in
girls.
adolescent. I think it should be like a contraindication. In adolescent group, we should not be giving GnRH.
Absolutely.
Bone loss will be a severe issue, no?
Yeah. So then basically hirsutism, of course, the counseling is most important, because we need to tell the girls and their mothers that there is no quick fix to this problem, and that the hair growth that has already started cannot be reversed completely except with maybe cosmetic treatment in addition to hormonal treatment. We need to stress that the treatment has to go on for a long time, 6 months to maybe a year. And nowadays we have some local application also like Hinder, which can be used in conjunction with the cosmetic therapy and maybe cyproterone acetate, to reduce this problem. Although I must say, being personally a person who has suffered from PCOS, this is a very persistent problem, very, very difficult to get over. So we'll now proceed with this is again a conclusion of what our esteemed panelists have mentioned. We come to the last part of our discussion now, and that is management of endometriosis in adolescent. We all know that the incidence of endometriosis is slowly going on, increasing in the younger population, especially because of the stressful lifestyle. I think, madam, you nailed it when you said that usually when they come into the 9th or 10th, they start facing all these problems because exams, colleges, and the need to do well in career, entrance exams, and those NEETs and CETs, they really take a toll on our young population. We have started seeing more and more girls coming at a younger age for their first consultation with signs or symptoms suggestive of endometriosis, and it is so common. 1 in 10 women with in the reproductive age group are going to face endometriosis at some point or the other. Now we have this young girl, 17-year-old, who has come to us with complaints of increasing pelvic pain and spasms during periods, but she also gets pain sometimes in between periods. Initially, she ignored the pain because everybody told her, oh, that's something that is very natural. But over time, it has increased. Now her mother is concerned. She's been through her family doctor. Of late, the pain has increased so much that she has to skip work or college or school. And her mother says she does not interact with friends. She started keeping to herself. Last few months, she's developed a definite increase in the pain intensity. She has taken a trial of NSAIDs in the initial part from a family doctor, but she only gets some partial pain. Clinical examination, she's young. We would rather not do a PV, but in a radiological examination, a 3 centimeter size questionable endometrioma has been detected. Probable diagnosis, I think we can fairly say adolescent endometriosis. Now her personal preference as of now is she needs improvement in quality of life. She's not planning to get married or have babies in the near future. So what would be the primary goals of treatment in this particular girl? Ashwini ma'am, would you like to start off?
See, I agree with you that this seems to be a case of adolescent endometriosis. And there is a dilemma that whether, we should go ahead and do a laparoscopy.
Very true.
For number one, to prove the diagnosis. Because, the parents are going to worry about any ovarian malignancy also.
Correct.
As soon as you
correct.
say there is a cyst in the ovary and the C120, if you do, it is borderline high, they are going to definitely worry. She's having pain, that whether she's having some other problem like a ovarian tumor and not just a endometriosis.
Very true.
So there is a dilemma whether we should go ahead and do a laparoscopy in adolescent girl. Definitely this is a dilemma, I would say. Or you just give her Dynogest or any other endometriotic against endometriosis, any drug, blindly without proving the diagnosis by looking at it properly in laparoscopy or taking a biopsy and draining the chocolate cyst. So
Right.
I would say you have put it in a 3 centimeter just to make us more confused.
Yes, ma'am. That was the reason I put it at 3 centimeters. Madam,
I don't think
for what patients we see as grassroots level clinicians in our practice are these patients, where the clear-cut guideline is not there, what to do with them. So that is why I want opinion from all our senior esteemed panelists
if
as
it
to
was
what
5
should...
to 6 centimeter, it was very easy.
Absolutely,
go
madam.
For laparoscopy, drain it. Maybe there are more implants. You just fulgurate those so that she doesn't develop into a severe endometriosis.
Very
and
true.
Then go ahead with whatever medicines you want to give, like Dynogest or with the other medical line of treatment.
Correct.
But these borderline cases are the cases
Yes.
where we often are in trouble. I think there we should also listen to the parents.
Correct.
If the parents and the girl is very, they are saying averse that we don't want surgery. They immediately like question,
Correct.
We don't want surgery. And maybe with their consent, I would say, maybe implied consent, you write on the paper that you have discussed the option of doing a laparoscopy. But now, because the parents and the girl, they are going more for a medical management, with informing them you are giving this Dynogest without doing a laparoscopy. But I
Correct.
think we should take their consent.
Yeah.
Correct,
We're
ma'am.
doing
Well
it
said.
even without seeing the
Well
ovary.
said. That first and foremost, we should try to rule out a malignancy, counsel them about the medical and the surgical treatment that are available. And also, I think they need to be counseled that this is a progressive disease. No matter what you do, it is going to go on progressing as age advances. It can cause a compromise of the fertility. That is something that the family needs to be brought up with. What are the host of medical agents that are normally available? Laul sir, would you like to
Yes.
mention?
First, I would like to say that I won't recommend laparoscopy in adolescent girls. That is the first thing I would say,
Right.
because
Yeah.
I think with so much technology available, sonography technology is available. I can do even transrectal sonography. If with their permission, I can small probe transvaginal is also possible. So chances of ruling out malignancy are, I think we can rule it out there and there only. And
Right.
she is a young girl of 3 centimeter. Clinical diagnosis is there. So what is the harm? Why should we talk about laparoscopy here? Why not going for Dinogenes like that?
Okay.
She
Yeah.
will get pain relief. The endometrioma will shrink. You will have follow-up sonography, because you see how many surgeries are you going to do. You said that it is a chronic disease, it is not going
Correct.
to go
Correct.
away.
Correct. Correct.
So suppose if she does not, then again 1 year second look laparoscopy. How many laparoscopies? And if you are starting at 14-15 years, then I don't know what the future holds.
Yeah, that is very
My
true.
my my take is that I would avoid laparoscopy as much as possible in a young adolescent girl. That's what I want to say.
Correct.
Dr.
So
Yeah.
Laul, I would like to just put one point forward that at least I will get a MRI done.
Okay, the
yeah,
MRI is
that's
okay,
a
sonography
very,
is
very
okay.
lovely
Some
point. Yeah.
Yeah.
safety for us, some safety for us.
Very
And
correct.
not for
Okay,
us, more importantly for patient.
I'm
For the
okay with
patient. Yeah.
with advanced sonography, Doppler studies. You get biomarkers,
Yes,
everything okay.
yeah.
But
But
that's meant
avoid.
to confirm our
Yeah. Yeah.
diagnosis of, and that there is no malignancy, so we can safely go in for diagnosis and be happy. Within 6 weeks we will know now
Yes, very
what is the condition. We
yes.
have follow up with the transvaginal sonography. So I won't open the topic of laparoscopy at that stage.
Right.
That's the point I wanted to make. That is, if I am forced to do it, and I don't think I would go in for 3 centimeters. I'm ever going to discuss
Yeah.
laparoscopy in a 15-year-old woman. That is my take.
Okay.
Yeah. Yeah. Same as me.
Okay.
Same opinion I'm having. I will never utter a word also about laparoscopy. Only I'll advise medical therapy.
Right.
Just to alleviate her pain, give OC pills and start Dynogest.
Correct. So that is what brings us to our next question, which is open to all the panelists, about what is your experience about Dynogest? How long do you give it? What is your opinion about the safety and the patient feedback that we normally get with Dynogest? Ashwini ma'am, would you like to start?
Dynogist, frankly speaking, I have never got a typical adolescent case, such early,
Yeah.
like what we are discussing, like 16, 17-year-old, so early. We have seen cases who are 20 plus. Usually
Correct.
they are the cases, they are young
Yeah.
girls or young women, we can say, that they are going on the Dynogest. Especially we have a good experience about developing again like a chronic condition. Suppose we have already done a patient with infertility or patient with pain, weak endometrioma, we have drained it laparoscopically, then we have started Dynogest. There is very good chance that she will settle down, and the recurrent endometriosis. Endometriosis occurring again. They will not give clear cut. Maybe Supriya, you can correct me if I'm wrong. They do not take it as a therapy for endometriosis. They have written it as a clinical indication as therapy for recurrent endometriosis.
Here there are some studies, ma'am,
Yeah.
where they have used it as a primary line of therapy.
Yeah.
This is exactly what I was going to come to. This is a large trial which was conducted in adolescent girls, 2 milligram of Dynogest given for 52 weeks. And they have substantially documented that there is definitely reduction in the pelvic pain, more than 40%. proportion of patients without symptoms increases by the end of therapy. So, they are recommending that you go ahead with, say, 52 weeks of therapy, and majority of the patients were quite satisfied with the therapy. Now, of course, the reason being the convenience. It's just once a day dose. The biggest factor going against it is the cost, of course, because for such a long time, the cost is going to be very significant. It has a great advantage to it that the BMD decrease is not going to be as bad as in using, oral contraceptives or GnRH, of course, which we spoke about. Intermenstrual bleeding and spotting, of course, we have to counsel the patient for that. We have to also counsel that she may get amenorrhea. In fact, that the amenorrhea will only be more helpful to her than otherwise.
Yeah.
So with this is what, the summary of this large trial came up, where they have, tried to check the efficacy of Dynogest vis-a-vis maybe COCs or GnRH. So this is what the study is at. Exactly what I want the panelists to answer. The 52 weeks is what is recommended, but what are your personal, experiences? How long have you been using it?
First, I always give for 3 months. I give a trial. And after 3 months, if she gets a relief, then it's very much useful for next 3 months, but not more than 6 months.
Okay. Ashwini ma'am, your take on this, how long to be used?
No, I agree with Dr. Alka that we immediately cannot write like take for 1 year, 2 year like that. We will have to give, as she correctly said, firstly even for 1 month and then come back. Then 3 months, then 6 months, then like that. But unnecessarily we should not be continuing. Also. That is also true.
Correct. Laul sir, your take on it?
Yes, I think the patient is seeking relief of pain here and improvement of quality of life here, and she is not seeking any fertility issues here. So I think Dynogest is a good option. She should have good relief with that, and if she is having good relief, there is, as both the panelists are saying, that you can give it for 3 months, again observe, you can continue depending upon the relief. I think that to my mind appears to be a very practical and rational way of approaching because as the patient grows, the patient needs may change.
Yes, absolutely.
So then we will have to rethink of what to do and how she is responding, has the endometrioma subsided or not.
Correct.
So all things considered, then this is, I think, an ongoing process. It's a chronic disease. It is not going to go away.
Very true.
Dynogest stops and again it comes back.
Yeah.
So
and
you
that
should
is
have,
why we need to counsel the patient right at the outset that it is going to progress no matter what.
And Supriya, we have to compare that which is the other alternative. Danazol is not a good alternative.
Correct.
So if we are going to shift from Dynogest to Danazol, I don't think we are going
There's
to
no point served. Yes, ma'am. There's no
Yes.
point served.
So
Absolutely.
depending on that, I think Dynogest is a better option nowadays, which is available.
Correct. So any closing statements that our panelists would like to make, because this brings me to the last slide. And if there are any questions from the audience, please put them in the chat box. So before we wind up, any closing statements, we can start with Ashwini ma'am.
Yeah, we have to tell the patient and her parents that, again, going back to the PCOS, that there is no cure for that. We can only control it.
Yeah.
And
Very true,
adolescent is a window of opportunity where we can tell her that if you don't want comorbidities to happen again, or in future some problems, like hypertension, then hyperlipidemia, and even CA, endometrium, etc. It will not happen if she focuses on her health throughout her adolescent years, and again throughout even till menopause. Even PCOS will remain beyond menopause. So we have to tell her that it is not only even till menopause. Even after menopause, this PCOS tendency, and because of that, the metabolic syndrome is going to remain. So this is a lifestyle issue, means throughout her life, that she has to remember.
Yeah.
Very well said, Venma. Very well said. Alka madam, what is your
and about this PCOS, many a times we have to answer the next question also. Madam, after marriage, can she have a baby? That is the issue, major issue.
Very major concern. Yeah, major concern.
They always ask this, and we have to counsel them that if she improves her lifestyle and she continues to take these medicines for a long, at least at present, then that is counseling is very, very, very important in these PCOS patients.
Very correct, madam.
Rather than this
Actual what therapy we give.
yeah,
I
other
totally agree,
therapies
ma'am. I
and all
totally
this.
agree. Yeah.
Because you should give your time for mother and daughter.
Yeah. Lowell sir, what message you would like to give to such
that
patients?
lifestyle management is the only drug available. Otherwise, you will be changing from one drug to another.
Yeah.
And one doctor to
One
another.
One doctor to
one
another.
gynecologist.
So first and foremost, join a gym, go for treadmill, lose the weight, and all be life member of that gym. And you will escape from all of us. You will become fertile. Your testosterone will go. Your hirsutism will go. Everything will be okay.
Very, very well said, sir. And
otherwise, Dynogest and all that are coming
all
in
are
your
useless.
life, and or for whole life you will be there. And God forbid, laparoscopy is ready.
Yeah, yeah. Okay, there's one question that has come from Dr. Uppal. Do you recommend Dynogest with ethinyl estradiol? Now we are getting drugs where, OCs with Dynogest as the progestogen. So any experience that the panelists would like to share about using it as a combination?
Especially, I think these OCs with Dynogest are basically for those women only who are with endometriosis. It's not not that we have to use only in them. But keeping them in mind, these OCs were made available.
Correct.
So definitely they have a role in women who are having irregular periods and endometriosis or recurrent endometriosis. And when we want to use any OCs for them, this is a better option than other progestogens.
Right. Alka madam,
Yeah.
sir, have you been using these?
No, not for adolescents. I'm not using.
I just heard from Dr. Nozer about the goodness of OC pills with the Dynogest. So I will take his word for him and say it's okay.
Maybe try it. Yes.
Maybe we can try.
Yes. So thank you very much. I would like to thank the panelists, and because it is Valentine's Day, so I'd like to finish this slide with a lovely message for all you people who are going to celebrate Valentine today. That love is blind. You can see these lovely two cats in love, and this is a lovely poem that I had put in my advertisement also. That roses are red, violets are blue, sugar is sweet, and so are you. So this is what when you are in love. Now marriage, on the other hand, is the eye opener. These are two people who are married for maybe 10, 20 to 30 years, and this is what they have to say to each other. The roses are wilting, the violets are dead, the sugar bowl has gone empty, and so is your head. So thank you all my panelists. Thank you all the faculty and all the people in the audience, you lovely people who spend their Valentine's Day with us. So here's wishing happy Valentine's Day to all of you, all my family, my friends.
Thank you.
And it's not just a celebration for couples. It's a celebration of love in all forms. Love is all around you, and may all of you be blessed. Thank you very much for a patient hearing. At this point, I'll just stop sharing my slides. And
Supriya,
yes, sir.
It is a pure joy to have panel discussion with you.
Thank you, sir.
It is highly enjoyable. I get to smile more and more. Thank you very much.
Thank you so
Supriya,
much.
happy Valentine's Day to you also.
Thank you, madam. Thank you, all of you.
She's a great moderator.
Yeah.
Thank you so much, sir.
Thank you.
It's an honor to hear those words from all of you. Thank you so much. Actually, Dr. Mahesh Joshi was supposed to compose the vote of thanks, but his mother is not keeping well, so he is not joining. So on his behalf, I will be just doing the honors. And at this point, I would first and foremost like to thank Dr. Rajiv Laul, our president, and Dr. Datta Panandikar, Secretary General, and entire team of TOGS for allowing me to conduct CME after CME under my Adolescent Health platform. We know that it is the need of the hour, and adolescents are our future. And this is a time which is well invested. I would like to thank our esteemed speakers, Dr. Shashank Joshi, who joined us from Sula Wines, and Dr. Nozar Sheria, yes, and Dr. Nozar Sheria, who joined us from the labor room to give us such lovely presentations for today. And thanks to all the panelists, Ashwini madam, for coming in last moment. I cannot tell you how indebted I am to you. Dr. Alka Godbole madam, Dr. Rajiv Laul, and to all my chairpersons, Dr. Senapati, Dr. Ajay, Dr. Rachna. A big thank you to Bayer, their team, Roshni, Mr. Dushyant, and Zoeb for giving us this wonderful platform. And I'm sure everybody else enjoyed every minute as much as I enjoyed doing it here.
Yeah.
There are lots of comments in the chat box saying that lovely program and excellent panel, and thank you all of you for all those kind comments. And we would just have like a closing remark from Dr. Laul, and then I think we will close this meeting.
Yeah, it's a highly enjoyable webinar. I think all the panelists enjoyed. The talks were too good. Dr. Shashank, Dr. Nozer opened our eyes to new aspects of how to manage unwanted adolescent pregnancies. Dr. Gandhi, of course, your insights are too good. We loved it. Thank you for coming at the last minute. TOGS is going strong, and with moderators like that, we are, I think, on our way to become a premium society. So thank you, all of you. And thank you, Bayer, for giving us this lovely platform. Please share the recording with us, because there will be a good demand for recording of this webinar. So again, we will see you next Sunday with webinar on better understanding of menopause with Dr. Ujjwala Bardapurkar. Do not miss our webinars. They are highly enjoyable. Thank
Yes,
you.
sir. So, and thanks to all the people who have been making comments in the chat box. Dr. Archana, Dr. Indrani Chandurkar, Yasmin, Rajneesh sir, all of you, Vatsala madam, Vatsala Vaidya, thank you all of you for your active participation. And we now close this meeting. Thank you all. Thank you, Ashwini ma'am, once again.
Thank you.
Thank you, madam. Bye-bye. Take care and happy Valentine's Day to everybody.